As you know, the Chair, Maeve McLaughlin, can't be here, so unfortunately, that's because of the weather. So unfortunately, you're stuck with me. As I say, I spent the morning in a fish factory in Kilkeel with the First Minister and have managed to get up here. I tell you, the conditions are pretty rough outside there for anybody who's thinking of travelling any distance. Can I remind members to switch off all electronic devices apart from your own little computer, apologies from the Chair, apology of course from both chairs, if you know what I mean, from Sue and from Maeve. Could I refer you to page 7 of your press release from the Minister regarding the approval of the framework for GP out-of-hours services? And can I suggest that the committee schedules a briefing on this? Obviously, it's good to access to GP services out of hours, and it's linked very closely in terms of people accessing A&E, so it's important we look at this issue. Are we happy that we schedule that meeting? And then can I refer you to the draft minutes of the meeting on Wednesday, the 5th of February? Page 9. Are members content with the minutes? I think we had a full turnout, so you're all there. And now we're going to have a very important issue that's arisen recently. We're going to have an evidence session on recruitment issues relating to the emergency department staffing with the NIMTA, Northern Ireland Medical and Dental Training Agency. So I understand that the witnesses are here. They're outside. I think I saw them, so I think we're ready to run. Yes, I was expecting that one, and I suspect there'll be a few others. Roy? Well, welcome, ladies and gentlemen. Can I just introduce you? We have Mr. Alistair, I'm going to get this wrong, Joins, who is the Chief of the Agency Board, the Northern Ireland Medical and Dental Training Agency, with Professor Keith Gardner, who is the Chief Executive and the Postgraduate Medical Dean, the Northern Ireland Medical and Dental Training Agency, and Margot Roberts, Administrative Director of NIMTA. You're very welcome. This is a very, very hot topic, as you know, an issue that's been raised constantly, and your name has been referred to several times during recent debates, so we're very keen to hear from you. I don't know who's leading off, but feel free. Is it Mr. Gardner?
Okay. I have included within the information we sent ahead some slides which you should have. I was just going to talk through those initially, so I've got a card just so that you can see where I'm got to in this. So I wanted just to start by explaining what NIMTA does. So it's responsible for the training of postgraduate medical and dental trainees across all of Northern Ireland, across all 5 trust areas, and in general medical and general dental practices. So altogether, there are about 1,800 medical trainees and 60 dental trainees that we are responsible for managing their training. We also would manage the appraisal of general practitioners, all the general practitioners in Northern Ireland who all need an annual appraisal. And we also provide continuing education or continuing professional development for general practitioners, general dental practitioners and dental care professionals such as dental nurses and hygienists. So that's just what NIMTA does to start with. Whenever we're looking at training doctors and dentists, we're aiming to do a number of different things. The funding, first of all, comes from the department. The ultimate product, the finished product that we're trying to produce, are individuals who are skilled in their specialty. That means they have the skills and the knowledge and the attitudes to be able to deliver that specialty at consultant level. But more than that, they also need to be able to lead in that specialty. So they need to be able to lead clinical teams. So they need to have communication skills, team working and leadership skills. In addition to that, then, we need individuals who will be able to improve service, because medicine's always changing. And if they come out today with a certain set of skills, that's not going to be out of date in 5 years. So they need the skills to be able to read the medical literature, be able to criticise it, understand it, and bring those new developments into practice so that the service is continually improved. Thirdly, we need to develop a number of individuals who have the research and development skills to move the whole of the health service forward, and the whole of medicine forward in terms of new medicines, to carry out original research into new medicines, new operations, and new forms of service delivery. And lastly, from a selfish point of view, as a training organisation, we need to develop the next generation of trainers and educators who will teach in the medical school and train in the hospitals. So we need to develop educators for the future. If we just move on to the third one then, which is about the structure of medical training. Undergraduate medical training is usually 5 years long. There is an accelerated programme for graduate entry of 4 years. So that's the blue column. And at the end of that, if the students are successful and graduate from university, then they may apply to enter foundation training. So foundation training that happens across the United Kingdom. Graduates from Queen's University could apply to any other medical school, any other training programme for foundation doctors throughout the United Kingdom. About 80% of the graduates from Queen's will actually come to us to enter our foundation programme. The foundation programme is 2 years long, and during that time the junior doctors spend 4 months in 6 different rotations. So if for the first year they're called provisionally registered, and they're under very close supervision, and if they gain the competencies and progress well during that year, then they will get able to be fully registered with the General Medical Counsellor and enter the second foundation year. So the first year will usually be spent in either a peripheral hospital or a central hospital, and then in the second year it's the opposite way around. At the end of the second year, then they can compete to enter into training in a specialty. And we'll go over briefly what those specialties are. The major 5 medical specialties of anaesthetics, emergency medicine, psychiatry, medicine and surgery all have a core programme which is between 2 or 3 years long. If they complete that core programme satisfactorily, then they can compete by interview again to enter into a higher training, higher specialty training in that specialty. And that training programme at the higher level may be between 3 and 6 years. If they get through all of that, then they will get a certificate of completion of training and are able to compete for consultant positions. So that's just the outline of that. If anyone wants to stop me at any point to ask questions, I'm happy for that to happen. Altogether, moving on to the next slide, number 4, there are 65 different medical specialties recognised by the General Medical Council, and in addition to that, then there are 39 subspecialties. So there are a whole range of different routes that trainees may follow during their course of their training. I've arranged it here according to inside and outside the hospital. So we've got the public health medicine, which are very much looking at what the public health needs are and commissioning services. We've obviously got the general practitioners who are working out in the community. And at the bottom in the sort of mauve colour, we've got the psychiatrists who are both working in the community and in the hospital environment. At the front door of the hospital, we've got emergency medicine, which I know is a focus of attention today. And behind that then, we've got a number of frontline specialties of medicine and surgery, paediatrics, and obstetrics and gynecology. And then behind that again, we've got the specialties which support a frontline doctor in doing their work. So for surgeons, it would be the anaesthetist to anaesthetise the patients to let them do the operations. And for lots of specialties are reliant on the laboratory work to analyse blood samples or to look at tissue specimens from the pathologists, from the radiologists to carry out investigations of imaging, and occupational medicine to look after all the workforce in the hospital from whatever discipline. When we look at what the rules are in training, moving on to slide 5, if we start at the top here, the department actually will provide the money for all this training to occur, but they also do the workforce planning. So they will give us guidance as to the number of trainees in different specialties that we need to train. The General Medical Council set the standards for postgraduate medical education. So these standards are for how the curricula should be designed, how the training should be delivered, how a deanery such as what we are, which deliver the training, should function, and the standards for how the trainers should act and what training they should have to be able to deliver the training. Next, down in the sort of pinky colour, is the Royal Colleges and Faculties. And because of the complexity of medical training with the 65 different medical specialties, the curriculum for each of these specialties is determined by a Royal College or a faculty. So they set the curricula in terms of what the contents that a trainee must learn, what examinations they must undergo and pass successfully, and what assessments they must get before they could come out as a consultant in that specialty. It's then down to the deaneries, such as NIMTA, to actually make sure that training is delivered. So we are responsible for recruiting trainees into the training programs, for allocating them to the different training posts, and for managing the training. So that very much, the GMC expect us to manage the training according to their standards, and we are held to account by the General Medical Council for doing that. And at the bottom then you see the local education providers, which are actually delivering the training. So that will be the NHS trusts, the 5 trusts in Northern Ireland, plus the general medical practices and the general dental practices. So they are the ones who actually employ the trainees. That's where the patients are, that's where the training is done, that's who provide the supervisors and the trainers, and they're expected to do quality control, and we're expected to hold them to account for delivering the training according to GMC standards. If we look at the funding for doctors in training, the funding comes to us from the department, which actually provides half of the salary of trainees in medicine. The other half comes via the Health and Social Care Board to the trusts, and that reflects the fact that the trainees are not just there to be trained, they're actually there also to deliver a service. So part of the money is coming through a training organisation and part is coming through the service. They also work out of hours, and there will be a banding for the amount of intensity and the frequency with which a trainee works out of hours, and that comes from the Health and Social Care Board to reflect the service element out of hours. If we look at how that's constructed then, in the daytime service, I've put the consultants in that sort of amber colour, so they're mainly around during the day, and then you get senior and junior trainees in the blue and the green. So again, because of the dependence of the health service on junior doctors and trainees to provide out-of-hours cover, 24 hours a day, 7 days a week, the trainees disproportionately do more work out of hours and at weekends than they do during the week. Moving on to the delivery of training. So that's slide 7. What we actually do, we work across from left to right. We do the recruitment and selection for all the trainees into different programmes in Northern Ireland. We allocate them to the different trusts and different general practices based on their preferences and how they've performed at interviews. They then require an induction to the training programme. The trust actually will employ the trainee, and they will provide an induction to the hospital, and then each unit to which the trainee are attached, that unit has to provide an induction to the training unit. The formal education of the trainees, we will have half days and full days of training at our headquarters on the Beach Hill Road, but a lot of the training will also be delivered on site in the units in their specialty. They will have a supervisor on that hospital site or in the practice who will supervise their progress from an educational point of view. They will obviously be carrying out practical work during that time, assessing, caring for, treating patients. and that, because they're trainees, that has to be supervised. So they have clinical supervisors who are responsible for the day-to-day supervision of their work to make sure that it's up to standard, to provide feedback, and to show them, to teach them how it should be done. They will get assessments done throughout the course of their training period in a unit, and that will all feed into an annual assessment. So each trainee, 1,800 of them, will all get an annual assessment each year by us to make sure that they're progressing, and if they're not progressing, to try and introduce remedial or corrective training to get them back on track. Unfortunately, there will be some each year who are not making progress who will have to leave a programme. We are also responsible for the revalidation of all trainees in Northern Ireland. So all doctors now, since last December of 2012, require to be revalidated every 5 years. There will be trainees who get into difficulty, either because of illness, whether it be physical or mental illness. Some will have problems with a particular educational learning, might be dyslexic. There are other trainees who will get into trouble with the police or be up in front of the General Medical Council, and part of our role is support trainees and to help them enter remedial programmes if at all possible. There will also be a track of academic trainees who we will work with the university to make sure that we do deliver on people who can lead the whole specialties forward. Less than full-time trainees is the last group. We have an increasing number of trainees because of now 60% entry of females into medicine who actually want to work less than full-time, who want to have career breaks. Moving on to emergency medicine delivery of service, I put this in 3 different tiers. So the fully trained doctors, the consultants, are obviously the ones who lead the service and will do a lot of the daytime delivery of service or leading of the service during the days. Increasingly, there's a move towards consultants being there for more of the week and more of the day, and I suppose there may be an argument for having 24/7 delivered consultant care to get the best quality care. The next group down I've called a middle grade, so I put this in very much in the context of emergency medicine. That is made up of a number of different groups. The group in amber is the trainees, and at that stage they're called specialty trainees, ST, in their years 4 to 6. And if you look at the Belfast Trust Emergency Department in the Royal site, they have 5 higher trainees in emergency medicine. They would also have a number of staff grades. There are different emergency departments which have GPs coming in to do sessions. So they'll be working in general practice most of the days, but come in and do sessions in an emergency unit. And of course then there'll be locums, who are people who come in for a shift, for a week, for a month, or for 6 months to fill in a gap. At the more junior level, again, the training grades are in the amber colours. So the CT refers to core trainees. So in emergency medicine, that is core trainees 1 to 3. And in the emergency medicine unit in the Belfast Trust, there are 2. There are locum appointments for training, otherwise known as LATs. These are usually appointed for 6 months or a year at a time. We have quite a number of GP trainees who will rotate through emergency medicine to get experience, which will help them understand how an emergency unit works whenever they're referring patients into it, and helping them in how to assess emergency patients. We'll have the foundation year 2 trainees who are the F2s. And then there'll be locums and nurse practitioners all working at that sort of level, assessing patients coming in on the front line. Okay, so just going on to the structure of emergency training. Sorry, this is a bit complex, but I'll explain it quickly if I can. The first 3 years of emergency medicine, because these trainees are having to gain a wide range of skills to meet anything that comes through the front door, they end up having time in a number of different specialties. So in the first 6 months, they will often spend that on emergency medicine, but they'll also have to do 6 months in general medicine and a year in total in anaesthetics and intensive care. So the implications of that is, if we recruit 4 trainees into emergency medicine, there's only going to be 1 actually in emergency medicine during that first year, because they're spending time rotating through other specialties, and that's part of the curriculum set by the College of Emergency Medicine. The last year of core training is spent entirely in emergency medicine. After that period of time, If they get their examinations, have satisfactory supervisors' reports and satisfactory assessments, they then complete core training in emergency medicine, and they can compete by competitive interview to get into higher specialty training. The size of the column here refers to the number of trainees we actually have in the programme at any time. So each year we bring in about 12 trainees into this core programme per year. So that in total, over that 3 years, we have about 36 trainees. You will see that the column for the higher specialty trainees is shorter in height, and that's because there are 6 positions each year at a higher level. So altogether, 18 posts at a higher level in emergency medicine in Northern Ireland. The bottom box is the locum appointments for training. Those are freestanding posts which only do emergency medicine. They're not coordinated with medicine, anaesthetics and intensive care, and therefore it doesn't enable them to progress along the training programme. The next one really just builds on that and says to indicate that at this vertical dashed line at the end of 3 years, trainees may go a number of different routes. Because of the type of training that they've undergone, they are attractive for other specialties to recruit. So it would be an advantage to an anaesthetist to have them come in, or intensive care to have them come in, or general medicine or general practice. So we find that even though they've gone through an emergency medicine core training programme, they will go off a number of different directions. They won't all stay in emergency medicine, and that's their choice to do so. So some may go overseas. We lose quite a few every year to go to Australia, and they can be very attractive again for the Australian government to have them come to work in Australia. We'll have ones who don't get their exams, who drop out of a programme, and obviously we'll have the ones who progress into higher specialty training. If we look at emergency medicine staffing in Northern Ireland, I put the staffing of all the training grades on this, and you'll see that the greatest number of trainees actually working in emergency medicine come from the most junior group, the F2 groups. They're only going to be here for 4 months in emergency medicine. They're coming in raw, essentially, out of foundation year 1. They don't have any experience. They need to be very heavily supervised. They're not the type of people that you want looking after you during the middle of the night as a sole practitioner. They're junior. They need to be closely supervised. You also have GP trainees who will be working there, and you see they're the second most common group. They need this experience to help them become good general practitioners. But again, whenever they're starting, they've never done emergency medicine before, and again, they need very much supervised. Then the next group are the locum appointments. This is the group I've shown. There's a blue and a red component, and this is where our vacancies in emergency medicine are all. So we have 18 posts altogether, and there are 9 vacancies. And that's because these posts are freestanding. They don't allow trainees to progress in a career in emergency medicine. They do give them experience. The health service does get some service out of them, but it's not a training programme because it's not matched up with anaesthetics, intensive care and medicine. The next year core trainees, you can see that half of that bar is blue, half is green, because only half of it's spent in emergency medicine. The other half is spent doing general medicine or anaesthetics. And the second year, there's virtually none of them actually in emergency medicine. They're out in the other specialties. CT3, they're back in emergency medicine, and you can see for the higher trainees, there are a reduced number because there's essentially only 6 per year, altogether 18. Moving on then to the last slide, and I suppose this is to give you a little bit of hope in the situation. The crisis in emergency medicine staffing is a problem across the United Kingdom. It's not unique to Northern Ireland, and as a result there has been an emergency medicine task force set up nationally within England, led by Health Education England, working with the College of Emergency Medicine and the Department of Health in England. And they have looked at this to see how they can improve the recruitment and retention within emergency medicine. So that's partly about promoting emergency medicine as a career, trying to make it more attractive, and trying to reduce any barriers or blockages that would prevent people from either entering or from staying in the specialty. So there's 3 different things I wanted to show you on this. The first is that from this year, and we are currently doing that, is we are recruiting trainees rather than into a 3-year programme, into a 6-year programme. So rather than have this block after 3 years, if we can get trainees in, we're hoping that they will stay in for the entire 6 years. This is run-through training. So that the block down the centre is being removed. Secondly, trainees who are ready in the programme and who are progressing satisfactorily are going to be allowed to stay in the programme without having to go through another interview. So that's the second component. So we're removing, again, that barrier. And the third thing is that there is a plan, and we will see how many we get out of it, to allow entry into emergency medicine from other specialties. So trying to get people in who have done core surgery training, who will have skills that would be useful in an emergency department, and there is a route of entry for them at the ST2 level, so they'd have to avoid having to do the first 2 years of training, and again it's to try and attract more people into the specialty of emergency medicine. To deliver that, then we need to expand the number of higher positions in emergency medicine from the 6 per year to 12 per year, and the trusts, because of the situation that they're in terms of the pressures that they're under and the number of locums and so on that they've appointed, have agreed in principle that they would fund the expansion of the higher specialty training positions in emergency medicine to get them up from 6 per year to 12 per year. So hopefully that gives you some sort of background. I'm sorry if I've gone through a complex area quickly, but I'm very happy to answer questions.
Thank you, Dr. Garner. That's very helpful. I think the vast majority of members would believe that this is a system that up until recently seems to have worked well and supplied an adequate number of the appropriately graded clinicians to man or woman. The feminisation, of course, it's men and women are A&Es. Now, myself and Kieran are very aware of the situation affecting both Lagan Valley, Ulster and Down. And quite clearly that has broken down because A&Es had to be removed at weekends from both Lagan Valley and Downpatrick because of the lack of middle grade doctors. And at the special council meeting which we attended to deal with this, the explanation was given that there simply wasn't an adequate supply of staff at that level to ensure cover at weekends, and the result is that they had to have closed the unit at a very short notice. And they raised the issue of the Australian problem, and they were told that 50 graduates a year are going to Australia. Is there no system that, having been trained in Northern Ireland, are they under no commitment whatsoever to then staff Northern Ireland hospitals, at least hospitals within the British Isles? Can they simply up and go?
Yes.
They can't. Is that a new trend, or is that something that could have been foreseen, and should we not have been training more to take account of it?
Yeah. I suppose after coming out of medical school, they need to do the first year somewhere in the UK. So the new graduates, to get onto the GMC as a full registrant, need to do the foundation programme. So they're going to need to do the foundation programme somewhere in the United Kingdom. And you'll see from the document I've supplied, our foundation programme positions are all filled. We don't essentially have any gaps. And the F2 positions in emergency medicine are all filled. The problem comes after the completed foundation 2. They can go anywhere in the world that will offer them a job. Obviously, Australia also have a need for people to work in emergency medicine, and a lot of our trainees at the end of the foundation programme will go off to Australia for a year or for 2 years. It's partly about life experience. Probably working in emergency medicine in Australia seems more attractive to them than working here. Well, it's probably something to do with climate, work-life balance and all those sorts of things.
Finance.
Pay, yeah. So, and this is not unique to Northern Ireland. I suppose the issue now is that before, trainees used to be very eager to get onto training programmes at a very early stage. Now they're actually choosing. It's a new generation out there, Generation X, who are actually choosing to say, I have a different aspiration for my life than people like me in the past who have gone straight in and competed and tried to get up the career ladder. They will say, no, in fact, I want to see a bit of the world. I want to do something different. and I can wait for my career to resume in 2 years.
Well, on the basis that we can't stop them making that choice,
Yes.
should the number of trainees not have been increased to a level to compensate for that, and should that not have been foreseen, say, 3 or 4 years ago?
Well, the number of graduates has increased, and I suppose there's reasons for that. Because of 9/11 and I suppose the 7/7 issues, there has been a change in the immigration to the United Kingdom from the UK Borders Agency, so that the doctors that were coming here before from India and Pakistan to get training here for a number of years are no longer coming. And those junior doctors would have staffed and kept alive a lot of different units throughout the United Kingdom in the past, but they're just not there anymore. They're not getting the visas to come into the country to work. So what that means is that has left a gap, and in response to that, then the government, both here and in the rest of the United Kingdom, has increased the number of medical students who are coming out. Whenever I was going through, it was 150 per year. This year there are 275 coming out. So there is not a shortage in the number of graduates coming out. It's what they're choosing to do thereafter. So if you put it up to 350, I'm not sure that will actually alter it. I still think there'll be people who are going, I suppose ultimately if you get it high enough, you will end up with enough people who will be so desperate to get a job they'll take any job. But at the moment, they're going other places in the world.
Well, I mean, the standard of the input in terms of A-level qualifications is getting higher and higher, so there's no shortage of capable young people in Northern Ireland wanting to do this. But you're painting a very bleak picture, because ultimately you're saying that because of the market forces and the people's desire to go elsewhere, we cannot supply sufficient doctors to man smaller hospitals out of hours.
Well, I suppose there's different models for staffing hospitals. You're looking to us, I suppose, because we are a training organisation, but what we are training is actually has to be followed from what you need ultimately. So we need direction from the top in terms of the number of consultants that you need, or the numbers of general practitioners you need, the number of trained doctors, and then that's what should drive the number of trainees that we train in each different specialty. Otherwise, we are producing a vast excess of doctors which you don't really need. So it's a lot of money actually to train these. So you're talking about £75,000 a year per trainee, effectively to pay for their salary and their banding and their training. So to produce more trainees than you ultimately need is going to be very, very costly. And also, I wonder if actually what we should be doing as a health service is actually look to a different model of how the service is delivered. It shouldn't be so dependent on trainees to provide the out-of-hours service and the weekend service. It should be more dependent on trained doctors, and the trainees' numbers should be aligned to what you need to produce the number of trained doctors at the end.
Is there another issue that has A&E and emergency become so unattractive for all the reasons that we were of, the bedlam that some of these places are like on weekends, and the whole issue of drink and drugs, and is the issue that we may be producing enough capable people, but they're opting to go down the GP route or the daytime hospital route rather than doing A&E? Yeah. Is that a problem you're finding?
No, I think you're absolutely right. I mean, if you look at where our vacancies are, the common ones we get vacancies in are emergency medicine, psychiatry and surgery. There's probably a number of reasons for that. Again, for the emergency medicine, if you look at, if I was a junior doctor in emergency medicine, I would probably be working here 3 weekends out of 5. Because a lot of the work is out of hours in the evenings and at weekends. That's when the units tend to be busiest, when they need to have the most number of staff in them, and that's when the doctors need to be rotated to be on. So I think you're absolutely right. There are pressures there. There is risk for the junior doctors in terms of being referred to the General Medical Council, being in front of politicians, being in front of media. A risk of getting litigation against them. If you've got a demoralised consultant workforce, it's also not a very good role model. So if they see their consultants burnt out and tired and fed up, they're not going to want to go into that. They'll look at them and say, don't want to end up like them. And so if you compare maybe working in general practice, which is now largely a daytime specialty, and a general practice trainee would be required to do 72 hours on call in a year. If you're working in emergency medicine, you're going to be working on social hours every week. So it isn't a very attractive career option currently. I suppose these moves that I've mentioned to you from the College of Emergency Medicine are one little step along the way, but we need to get to get people attracted into it, you need to make the working environment less hostile so you don't get so much abuse from staff, you're not under so much pressure. That almost needs to be fixed before you can actually get it attractive enough for other people to want to come into it.
I've got Kieran and Roy and Fergal and any...
I mean, most of what, to my mind, you have covered.
We're at the same meetings together.
100% in support. But I don't, surely it's not impossible for within the service to visualise what is going to be needed. I think you said, Keith, that it's difficult to know how many people needs to be trained up. I'm not convinced that would be the case. Surely the powers that be are in the system long enough to know and what to expect, and therefore that should not be insurmountable. I would have thought, but I hear what you say. But and if we had a bigger spread of people to do the work, it would mean surely that they would be required to do weekends less often, and that would be more attractive. And just finally, Chair, is there any incentive that could be thought of? I don't know, bigger salary or something along those lines that could attract the right people to do the jobs that we're looking for?
This has been changing delivery. Whenever I was a junior doctor in emergency medicine back in 1984, virtually all of the service was delivered by junior doctors. There were 2 consultants who worked in the unit. If you go to a unit now, you will find that most units will have 4 or 5 consultants. Some of them might even have 10 consultants in emergency medicine. So there has been an increase in the number of consultants over the years. So you're right. There's a difference. There's been a moving in terms of who is actually delivering the care, and I think that's the right move. If I was going to emergency department, you were going to emergency department, you would like to think that your care was being either delivered by someone who knew what they're doing or carefully supervised by someone who was an expert in that specialty. The ultimate step of where we're leading with this is probably consultant delivered care in emergency medicine 24 hours a day, but you're going to need teams of 16 consultants per unit to deliver that. So that means you've got to have a big expansion in the consultant workforce in emergency medicine. So if the department come to us and say that we need to increase, the workforce plan now is that we have 16 consultants working in, say, 5 different units, then we will deliver that training. We might need some investment to produce the training posts to do that.
The worry, the investment is not there, or reluctant to put the investment into where we want to get to?
Well, I think there is some work ongoing at the moment by the Public Health Agency to look at workforce planning for each different specialty. It does take time to work through that. It's a complicated model. They're looking at what the average age of appointment of a consultant in a specialty is, how long they're spending in that specialty, when the retirements are coming up, and what the plan for the service is. So we need a clear direction for what the plan for the service is first, and then we need to know who's already in post, so we can work out going from A to B in terms of the expansion that would be necessary. At the moment, we don't have the flexibility to say, well, we've got too many trainees in surgery, let's move the money from surgery into emergency medicine, because we only have actually half of the salary of each trainee. So we can only move half of that salary from one area to another. And if we did move a trainee salary from surgery, for example, to emergency medicine, then that could destabilise a surgical rota and cause a collapse of a surgical service in a particular trust. So if you were really wanting to do that expansion without affecting any other service, then you need to put more money into training to deliver an expanded number of trainees to meet a consultant expansion. So, for example, in oncology, you'll be aware there's going to be a new unit for radiotherapy being delivered in Altnagelvin. To get ready for that, we appointed extra trainees 4 years ago, so that by the time that unit opens, we will have the trainees coming out to be able to staff that unit at a consultant level.
And hopefully not on Bondi Beach.
No, hopefully not on Bondi Beach.
No. I mean, thanks for that response. Just finally, it is disappointing whenever you mention retirement. You know, it's a cycle. Whenever people come to retire, there is no one there to take place, and that is a disappointment in the service for people that expect the service.
Yeah, well, I suppose, again, people can retire at different ages, and there will be a choice over which they can retire. You can do some sort of predictions. You can look at a specialty and say, well, what's the average age of retirement in that specialty? And if you use that as a marker, you may be able to predict better when people are going to retire and replace them. But you do get people who will, particularly in stressful environments, will pack up earlier, or just say, I've had enough of this, and maybe you'll get stress or retire on ill health grounds.
Okay, thanks, Joe.
Declare an interest in case emergency dental treatment might arise during the conversation. I have family members who are dentists. You've highlighted the heavy workload, the unsociable hours, and the high risks of working in emergency medicine. And I'm just conscious that what you seem to have explained to us is the new plan is not going to make much difference this year. Is it going to make any difference next year, or is it not? Do we not need to be more radical in solving this problem?
Well, I suppose there are things that we can do and there are things that we can't do. I mean, there is a possibility that you could expand the number of, I suppose that what I've talked about here is an expansion in the number of higher trainees. That's what we're hoping to do. But clearly, in the paper I've illustrated to you that the number who we've got in this year, because 2 of them are going off to Australia and 2 of them haven't got progressed well enough, we're not going to actually be able to have an expansion this year. So we could look at also expanding the number of core trainees, but you can see it's not a very efficient way of getting numbers out the other end or getting service from them during their time, because of the way that the training is actually structured. So that actually they only spend 25% of their time in the first 2 years in emergency medicine. So if the department came to us and said, we will give you extra money to create extra training posts at a core training level, we will do that. Our block to doing that currently is that to complete their training at a core level, they need to go to emergency medicine, to anaesthetics and intensive care. They're not much use in that environment. So they're not actually contributing much service because they're coming into highly specialised environment without skills. By the end of the 6 months in those environments, they will have their skills, but by that time they're moving on.
My concern is particularly that this problem has existed for some time. And I look back to an Assembly question 3 years ago by Alistair MacDonald, where in terms of the Royal, there were 8 middle grade doctors to be available, 4 unfilled posts, 8 junior grade doctors, 2 unfilled posts. And if you look at the weekend rotas, the consultants weren't on duty, so we had no consultants, the consultants were on call. So we had no consultants present, and we had an undermanned middle grade doctors 3 years ago. So what has happened since 3 years ago to try and solve this problem?
Well, in terms of what we can do, I mean, I suppose we have volunteered for this run-through training with support from the department. That's been the major initiative which has happened in the last 2 years. In terms of actually filling our training posts, we have been very successful at filling our core training posts in emergency medicine and filling the higher specialty training posts in emergency medicine. So in terms of the actual career progression posts, we've actually been more successful than most of the rest of the United Kingdom in filling those training programme posts. The problems we've had is attracting people into the short-term posts which are freestanding, and that's why there have been vacancies. So we have tried to promote emergency medicine as a career. We've put it on, we have an annual careers fair. We made sure that emergency medicine features each year, and as in a positive light as we can. If you want us to increase in more training posts, then we need to be given money to do that.
What else has been done to ensure that this is more attractive? Because unless you get people in here, we're not going to change anything. And in particular, it does seem to be that there are limitations which are stopping people going in here, and that they have to be overcome. For instance, GP training, can you require people to be there longer so they actually contribute more? If you want to be a GP, you have to have served more time. Has there been some radical thinking to ensure that the public money, the billions of pounds of public money, actually delivers the service that's needed and not just meets the needs of some people who wish to go a particular direction?
Okay, well, the GP training, again, the curriculum and the requirements of the GP training is set nationally. And it's agreed by the GMC. So there's a curriculum which is submitted by the Royal College of General Practitioners, which is approved by the General Medical Council, and we have to work to that curriculum. Emergency medicine is not an essential component of training in general practice. If it was, it would help with a number of general practice trainees who were in emergency medicine. It would probably help them in their future careers in dealing with emergency patients, and it would help the service in providing a contribution to the service.
So why cannot not be changed? I'm conscious at one point very few civil services wanted to go to Brussels to get experience, but it's essential there were experience of Brussels to be able to draw down funding and schemes that would benefit Northern Ireland. So an incentive was put in to reward and ensure that that would happen, and that did bring about improvement. So why can incentives not be brought in to reflect the benefits that comes to society and to the doctors' training involved to ensure that we have the necessary man-hours?
There is a new group which is called the Shape of Medical Training, which is looking at how training is delivered across a whole range of different specialties to try and address what the need of the service is, which is what you're really coming to try and tie in what the output of the training is more closely to what the service is. And there is consideration that as part of that, general practice training may extend from 3 years to 4 years. Obviously that will come with a cost, but within that cost, emergency medicine, for example, in Northern Ireland, might have general practice might have 6 months of emergency medicine built into it. But that is probably several years away before that could come in, and hasn't been even agreed. It's just been floated as an idea. But I think the point you're making is well made, that that is a potential method of getting general practitioners useful experience and getting the service a useful service.
It's clear the problem existed 3 years ago. How are we going to ensure that it's not going to exist in 3 years' time?
Well, I think one of the things that obviously we can do is to try and support as vigorously as possible this run-through training. As I say, we have some blocks into moving money from one particular specialty training into another block. If we had, for example, control over 100% of trainee salaries, then we could actually move trainees from one specialty to another. We would need political support, departmental support, because obviously we're going to get some flack for that. We're going to end up removing, for example, core surgery trainees or core medical trainees to create more trainee opportunities in emergency medicine. That you will then possibly get, all of you, some grief from your local hospital saying they're destabilising your service. So we would need support to say that for the greater good of emergency medicine in the future, some of the resources that are in other disciplines need to be redirected towards emergency medicine to provide a training pathway to more emergency medicine consultants. Either that or additional money needs to be invested to provide that expansion of training posts. So those are the two options. Either expand the number of training posts or you move money from somewhere else, but there are barriers to moving money from somewhere else.
Thank you, Chair. And Professor, to start, can I say thank you very much for your very clear, concise and comprehensive presentation. I think it presented very well and gives us, I think, a greater understanding of your service. And at the outset, I'd also like to say, commend staff in accident and emergency units who face daily pressures, which we're all aware of through recent headlines. Obviously, you're talking about the supply side, if you like, and training to a capacity. But if the capacity or the demand side was different, would that reflect differently on your needs? In other words, we understand that something in the order of 30%, potentially up to 30% in the Royal are presenting and shouldn't be there in the first place. So if the demand side was altered, would you be having a different discussion today?
Well, I suppose with transforming your care and the idea of shifting the care from the community, from the hospital sector into the community, then you would need more people in the community to manage those patients and keep them in the community and avoid pressure. So I think that is an ideal which is strived after throughout the United Kingdom, and in fact the Health Education England, which is the body which is responsible for training all forms of all professionals groups in the health service in England, have decided that 50% of the output of training in England should be general practice trainees to provide a workforce to manage patients more in the community.
Could we change the demand side, and would that therefore impact on your presentation, if you like, and you would now be talking about GP?
Yes, I suppose the service needs to change first before the training. The training should really follow the service. So what the numbers we should be delivering should reflect the workforce planning that's been done, and where we do the training should reflect where the patients are. So if the patients are more treated in the community, more of our training should be done in the community. And if there are more doctors who are going to need to be working in the community from a general practice or a hospital background who are now working in the community, that's what we should be aiming in to train.
Would that, in your view, resolve some of the issues around crisis in accident and emergency?
Yes, I think it would be helpful. Yeah. I think that the problem is that because of either patient perception or lack of availability of out-of-hours service, more patients are going to emergency units than need to be there or should be there.
You've helpfully included the poster or the fact sheet from College of Emergency Medicine in the worksheets here.
Yeah.
And do you recognise then that claim that accident and emergency is anything and everything as a public perception?
That is reasonable. Yes, I've been a surgeon for the last 30 years, so yes, I know exactly what it's like to be on the front line of emergency departments.
You also reflect, or this also reflects, that crowding increases mortality. Are we saying, therefore, that people are dying in our accident emergency units as a result of overcrowding?
Well, I suppose as a training organisation, we wouldn't have that data. That's the type of data that would be held within trusts. We do get concerns raised with us by trainees about their training and the impact of workload on their training. So we do get, I suppose, what you might call as intelligence coming to us from trainees about the work pressures. They sometimes will raise patient safety concerns if the work pressures are intense or they're worried about patients getting lost in the system. They will raise those concerns. But we actually don't have the data on the number of the total number of incidents of that or what the reasons behind that have been. All we've got is the trainees who have got concerns, and then we will bring those to the attention of the trusts.
I'm reflecting back on this document, but it's included in your literature. And what do you understand by the reference to perverse incentives producing dysfunctional systems?
I suppose what we're talking about there is that I obviously didn't write this, so I can't give you a complete understanding for that, but I suppose in general practice there is an incentive to on payment for service, essentially on getting various targets hit. For example, getting people's blood pressure measured, getting their cholesterol measured, and hitting all those targets, which are very good from the preventative point of view, preventing diseases for years to come. But it might mean that there is less capacity in general practice to deal with people who have got an urgent problem, so they maybe cannot get an appointment with their general practice as quickly as they would like. And in today's world, where there's a degree of consumerism, they're not going to wait for 2 days or for 3 days or for a week for an appointment. They'll go along to the emergency medicine department because they want get an answer and get it sorted out today, even if it means waiting for a number of hours.
That's right. The number of hours may be more attractive than a number of weeks. And if we dealt with the number of weeks issue, it's almost like an ergo.
Yeah.
We would be substantially dealing with the problem. Is there an issue around, and you did go through it quite quickly, and I did say it was clear, but if this is something I've missed, forgive me. Can emergency doctors get training points in the same way as others get them? In other words, could that be an attraction within the system?
I'm not sure exactly what you mean by training points. Could you explain that a wee bit better?
I'm not entirely sure. It's something I heard anecdotally, but it's around the equitable. Does everybody get trained in the same way? And does emergency, is it classified as the same scalability, if you like, or attractive?
In terms of pay, do you mean?
No, I didn't mean
No,
that. I meant
okay.
it in terms of a training score.
Well, I suppose it's hard to give you a straight answer to that, because each trainee has to follow the curriculum in that specialty. So each specialty is going to have a different curriculum and different requirements. In terms of how we deal with them, we would expect them all to get an equal quality of induction, of formal education, of supervision, and of support. So we would expect them all to get the same standards of support, and all would be seeking to get the highest quality of education no matter what discipline they're in. If they're in a hard-pressed specialty, it could be the case that the service could impact on the education and make the education, the training, more difficult if it got an intensive workload, and that would be one of the markers to us of concern, if the workload is so intense that in fact they can't actually learn.
Yeah. And Chair, just one final point. I'm conscious that I'm taking up more time than maybe others, but is it possible that at the start of training that the contract begins, if you like, and that contract would extend to staying here as a result of your training rather than going further afield?
There's no method that I know of at the moment to do that. Margot has maybe more.
Contract is signed, it takes a break, you pay a fee.
Yes.
I think it also has to have to reflect on the sort of BMA and other organisations that would that have traditionally negotiated very strongly on behalf of doctors at every level, and that might be very difficult to get a contract that would be so binding.
But it wouldn't be impossible at the start of training for a contract to be signed which says, I commit as a result of this training to staying in either hospitals or service in Northern Ireland or the UK or whatever.
Would there be a corollary to that, which would be, would you commit to provide them with a job?
And maybe, yep.
So you see, we could end up with, say, 10 trainees coming out in obstetrics and gynecology and not need them. Okay, so at the moment we have no commitment to provide them with the job. We've committed to provide them with the training, and then they can go and seek a job anywhere in the United Kingdom or elsewhere in the world.
Maybe I could turn it the other way. Has any work been done on looking at the dynamics of just such a contract either way to see whether it's a valuable addition to the solution?
I think we would have major objections from the British Medical Association, and it would be out of keeping with the rest of the United Kingdom, and be essentially offering them different terms and conditions of appointment to a training programme.
You spend 75,000 a year training them, and they can do whatever they like at the end of that.
You could do.
I think the problem
But
for
most
us
of them
is-
actually do want to stay.
Sorry, just the problem for us is we're not the employer of these trainees. We're just the organisation who recruits and
Understood.
trains them and assesses them and so on. The employment contract rests with the individual trusts, so there would have to be a national agreement in relation to that. And certainly if we were told that we as an organisation could act as the employer, it may be something that we could possibly look at. But the BMA, I'm sure, would on behalf of the trainees, of the junior doctors, would probably be fighting that very strongly.
Thanks, Chair. Thanks very much indeed for your very informative presentation. I think it's been very straightforward and useful. Just most issues have been covered, I think. Funny enough, doctors in training, running up the out of hours, to me, in your illustration there, Keith, is quite clear that the out of hours is being run effectively by junior doctors. So there's little or no expertise there for the public when they go. So as a result, we're probably getting those people moving over into A&Es in our hospitals. Is that an issue that needs to be addressed? And what struck me was, and you mentioned it, we have no consultants at that point. Is it a problem that consultants are not willing to work the out of hours, the unsociable hours any longer, and are selective in when and what they're doing, so much that they don't want to be engaged in this out of hours work?
Okay, well, I suppose traditionally, and this is where you're coming back to, traditionally consultants have generally been on the ground during the daytime hours and provided an on-call service out of hours, and that's why the contract has been set up. I think there are consultant contract negotiations going on at the moment to get that consultant contract changed so that you'll be able to work, our contracts will be able to set up so that people will work out of hours routinely as well as in hours. So at the moment, all the surgeons, while they may be in during the night operating, they're not required to be there throughout the night. Now, emergency medicine, I know there are some trusts that they've managed to persuade consultants to work into the evening, and they work routinely at weekends, but you still don't have anywhere that I know of in Northern Ireland 24-hour-day consultant cover in an emergency unit.
So that's a vacuum then that needs to be filled.
Yeah. You do have middle grade doctors, some of them who are associate specialists or staff grades or middle grade trainees working during the night who will have some years of experience in emergency medicine, and they can call their emergency medicine consultants, or if there's a crisis they could bring them in. But there is a difference between having the consultants actually present and having them on call.
Absolutely. It's back to this thing, the out-of-hours service needs to be used more by the public. We need to do more to encourage people to use it. But people don't, if they are aware that consultants are not available, they have a lack of, I suppose, of confidence in the service, and therefore they go direct to the A&E. And again, it's just trying to address this problem, ongoing problem of people going to A&E that shouldn't be there in the first place. And to me, that's an issue that needs to be addressed. Just on the A&Es generally then, you're saying that we couldn't run it without the junior doctors?
At the moment you couldn't.
You couldn't?
No, and in fact that happens, that's applying not just in emergency medicine but across all acute specialties, that it is based currently very much out of hours on the junior doctors.
But why is that? Is it partially because the doctors and consultants can be selective in the work that they want to do? Should trusts not be pushing doctors towards working in these A&Es?
Well, of course, if you have the consultants working during the night and there's a 48-hour European working time limit on the amount of hours, so if they work at night, then they're not going to be there during the day, and you're going to have a reduction in your throughput of elective work during the day, either reduced number of patients coming to clinics or reduced scopes being done in a day procedure units or reduced operations being done. So you either have to, possibly double the number of consultants to maintain the same service, but obviously you might get a better service to the patients out of hours, maybe a more efficient service out of hours, but it is going to come at a cost if you're going to have consultants provided 24 hours a day.
Should we not also have the power, should NIPTA not have the power to tell people where they're going? Yeah. Because at the minute, they always will graduate towards the big teaching hospitals, the Cities, the Royals, the Elms of this world. They prefer not to come to Downpatrick or to Coleraine or to the Lagan Valley. Now, what would be wrong in saying, if you're needed, no matter what grade you are, you will go there because we need you to cover those hospitals, rather than saying, I only want to work in the Greater Belfast area?
Okay. I think this has been raised with us before. We're not unfamiliar with this problem. There are a number of reasons which will impact on where trainees are placed. We have training posts throughout all the trusts in Northern Ireland. Not in every specialty in every trust, but throughout all of them. If all the posts are filled at recruitment, then all of those posts and all those trusts in that specialty will be filled. If we have vacancies, that is probably where the problem will arise. Where people will get placed will get based on how they perform at interview and partly also on their preference. So, for example, in general practice training, we have 13 posts in each of the 5 trust areas. So we get 65 in each year, 13 go to each of those 5 areas. Foundation, they all go to all those different areas. It's the specialties which are hard pressed where the vacancies are going to arise. We don't actually have any trainees in emergency medicine at Downpatrick and have not had any trainees in emergency medicine at Downpatrick. So it has not been a withdrawal of trainees which has been the problem. It may have been a problem recruiting middle grade non-training grades, but it's not trainees. The trainees, yes, sorry.
Just on that, Downpatrick, what's it, 28, 30 miles from Belfast?
26 from the Royal. It's a long
26
way,
from
isn't
the
it?
Royal. You know, you're not, it's not, you know, they were 100 miles away at Belfast. You've the greater area, you know, the greater Belfast area for people, majority of people reside within Northern Ireland, and yet you're saying that there are posts in Downpatrick that are
No,
30 miles away and you can't get them
we've
filled?
never had training posts in emergency medicine. No, we just don't have them. It hasn't been a problem. It hasn't been that we haven't been sending them. There aren't any training posts in emergency medicine in Downpatrick.
In Valley, and it takes them 20 minutes.
Yeah.
But I think they've had it, maybe perhaps they've had it too good for too long, and I think maybe there needs to be some more direction, and managers need to start managing, and I think that's where it really has to be taken on board, and people need to be, in any organisation, people will do the work that's easiest to do, that's easy accessible, but where there are difficulties, where there are challenges, people avoid, and perhaps that's what is happening, that the medical professionals are avoiding where there are risk areas. And you also mentioned, Keith, sorry, you mentioned the point about the risk is increased, and this is something the media picked up, and the risk is increased in A&Es in the evenings, at nights and the weekends. Now, should that be the case? Surely the resources should be managed that the risks are reduced. Now, we need to take action now to reduce those risks and have medical professionals in place to manage those risks right throughout the periods when people need to attend hospital.
I maybe will defer to my service colleagues because that's really a service issue.
You're a training organisation.
We will look for. We're going to be looking for where the highest quality training is, and we want our trainees to be in those high quality training units. Because what we're looking for is actually to produce the high quality finished product at the end of the day. So we have both a long-term view and a short-term view. So if I was looking to where I would get the best training in emergency medicine, I would be looking for which unit has got the biggest range of patients, the biggest volume of patients, the highest quality of delivery, and all the support services. So I'd want a unit which had anaesthetist on site, had surgeons on site, had an intensive care unit on site, because that is where you're going to get the best quality training. And you want a unit where there are not bypass procedures in place. So, for example, trauma will bypass Downpatrick, acute cardiac events will bypass Downpatrick. So the trainees, if they got sent there, are not going to get a full range of exposure to emergency situations. Do you understand what I'm saying there?
They want no mention of the need of the community. It's what they prefer.
Well, there's a need for the community. Ultimately, you want the best trained doctors looking after the patients in Northern Ireland. That is a long-term aspiration. That's what we are there to deliver, is a finished product which has got specialty expertise, which can lead the service, and that's a long-term view. So if you want the highly trained product at the end of the day, they've got to go to high-quality units along the way.
It's this issue.
But we want the best trained in the right place so that the patient gets the best outcome.
Yes.
That's what we want. So in other words, that equation has to be complete.
Yes.
It isn't just about having the right person somewhere. It has to be in the right place. It's a point the committee
From
would
our
accept.
point of view, though, obviously we have to ensure that the curriculum can be delivered onto the individual, that they come to the end of their training year and they go through their assessment and they move on to the next year of training. If they've had limited exposure within a unit, then clearly they won't be able to progress. and that then represents another problem for us and for the future.
I think coming back just to your point, it really depends on who do you want to be the trained doctor in that unit? Who do you want to be delivering the care, delivering the service in that unit? Ultimately, I think it should be people who are fully trained, should be leading and delivering the majority of the service, rather than trainees. And the trainees should be there to get the best possible training, but can they do that through contributing to the service? So that I think, you know, we need to be able to deliver for you the best quality trained professionals at the end of the day. And the only way we can do that is by making sure that they get the high quality training along the way, and that's the breadth, the quantity and the quality of supervision.
Professor, for your presentation thus far. When you come in and sat down, I saw the name Keith Gardner. I said, what's my son coming here for? He repairs cars, not human beings, but thankfully you're on the right side of repairing human beings. Thank you for your presentation thus far. Professor, could I ask you, why do we not recruit new super paramedics, as has happened in Wales and in London? Surely this would be a lesson to lessen the pressure on the A&E departments.
So I missed the word that you said.
Why paramedics?
Paramedics.
Yes. Why do we not recruit new super paramedics, as has happened in Wales and in London?
I think that is a model that could be looked at. I mean, I suppose what I'm really saying to you is that not all care in emergency units needs to be delivered by trainees. There's a whole spectrum of people who could do that. So you could prevent people coming in by getting better service in the community. You could have advanced nurse practitioners. You could have paramedics. You could have trained doctors who are specialty doctors but not consultant level. So you can provide other models of delivery of care. Paramedics would be a very good group who actually would have many useful skills in resuscitation, in intubation, in dealing with the acutely ill, who could provide a very valuable service in our emergency units. We don't train paramedics. So I can't really say, we're not commissioning paramedics. So I think that's a very good suggestion. It has been used elsewhere. I would support it. We don't have the power to actually deliver it for you.
You throw your weight behind it. We'll do our best from this committee.
Okay.
I think David wanted to come in, and then I think Roy has a point he wants to raise. David?
Thanks very much, Chair, and thank you for your presentation. Obviously, I take on board the fact that you're a training organisation primarily, but I suspect now that the trusts have become very much reliant on the fact that you're delivering, a fairly significant number of, I suppose, fresh bodies into the system every year. So I would suspect if NIMDA had disappeared tomorrow, there would be a few trusts sort of panicking about where are they going to fill their pressures for this year. My understanding is your sort of training year starts in August around, is it the first Wednesday or something in August? Yeah. And I suppose what I wanted to try and maybe get an understanding of is at what point would you be informing the trusts that certain specialities are not going to be receiving the number of recruits that they were expecting?
Okay. So the recruitment has already started. The applications have been coming in since really from December. We're into recruitment. That started in January. That will probably go on for about 4 months. We're, I suppose, still in round 1, and there'll be a round 2, and sometimes we'll have a round 3. But basically, what we have undertaken to do is that if we can obviously fill all the posts with the first round of recruitment, that's absolutely fantastic. In some specialties, we do that. In emergency medicine, we will usually have a round 2, and we're planning for a round 2 this year again, because we anticipate that we'll have difficulty filling these short-term or these fixed 1-year posts, as we've had in previous years. The interviews have happened for the first round. The offers have been made, but we haven't heard as yet whether people have accepted those offers. So we can't tell you up to date today where we stand. But we have planned a second round of interviews for emergency medicine. Last year we went to a third round, so that each round takes a number of weeks because it needs to be advertised. Trainees need to give an opportunity to make travel arrangements to come for interviews. Interviews need to happen and offers need to be made. So the cycle goes on. So we really only can get 3 rounds of interviews. We did it last year in 2 different specialties, in emergency medicine and in core surgery. But that can go right on into May. Where we try to let the Trust know is by the end of May or the very start of June what we've got to in terms of the fill rate of these posts. So really at the end of May, beginning of June, we will be telling the Trust what their allocations are for the start of August. And we will be telling the Trust that we cannot fill all the posts in this. And we will usually leave the money, the training money, in the Trust to enable them an opportunity to try and fill those posts, even at a late stage, with non-training grades.
So locums.
Locums.
Yeah, yeah. And one thing that jumped out at me in the emergency medicine staffing graph that you showed was I was quite astonished by how many GPs find themselves in emergency medicine. I mean, it's basically all of them. And I suppose going back to the sort of opening questioning that we had around numbers and allocations and balancing everything in that particular way, why not just increase the number of GP trainees?
Very expensive. We pay the 77% of our entry of GP trainees last year were female. It's more sort of family friendly, less out of hours work. A lot of those trainees will have maternity leave during their GP training. And some of them will want to come back then and do less than full-time training. So probably, even though the training programme is 3 years, often trainees will spend 4 years doing it because of maternity leave or working less than full-time. We end up paying the salary for those GPs because they're actually out in practices, so we end up paying 100% of the salary. So it is actually very expensive to train a GP in comparison with a hospital doctor because we end up having to pick up their maternity leave costs as well.
So the graph, as it stands at the minute, is probably something from the GP point of view that you'd want to see going in the other direction.
No, I don't think we plan to reduce the number of GP trainees.
I'm just thinking. I mean, from the GP trainees in emergency
medicine. Well, I suppose I think it is useful training for them, but they have 5 different specialties that they can get recognised for their training. So it'll be obstetrics and paediatrics and medicine and emergency medicine and psychiatry are the 5 different specialties which will count towards their training. But as I said earlier on, emergency medicine is not a compulsory part of their training. It's one of the options, but not a compulsory part.
And finally, just through the chair, a slightly different matter, just around retention of trainees. And obviously, I'm conscious that we've had a fairly broad conversation around those who decide to go to different countries and so on. However, for the ones that find themselves remaining here, but either pulling out of their training or not then finding themselves in a position to go into a full-time position. You'd mentioned, Professor Gardner, around trainees raising concerns, and I think this is where I think NIMDA are in a very privileged position because you do have fresh eyes going into the service. And I suppose, and it's probably difficult to say this without sounding a little bit unkind, but you know, those who are maybe have been working for the health service at a clinician level for a number of years, probably maybe find themselves a little bit ingrained in the culture, and perhaps don't maybe see some of the things that are perhaps going on around them, which maybe do need to be called. And I think you had made mention that. You know, certainly there is times that trainees will come to the deanery and will say, you know, we have genuine concerns around patient safety. Taking that to its next step, I mean, have you any experience in the past of trainees coming to the deanery who have actually effectively taken on the position of a whistleblower and have subsequently found themselves being bullied or harassed by maybe more senior members of staff?
Most of the time, the trainees can raise concerns in a number of different ways. They can raise it through trust processes, through incident reports, or speaking to their clinical supervisor or their clinical director. So that's one route they can do it. They can also raise it through the General Medical Council's survey. So every year the General Medical Council has an annual national trainee survey, which is across all of the United Kingdom, and the GMC will ask the trainees, have they had any concerns about patient safety? If they do, then the GMC will send those concerns to us to get them investigated, responded to and addressed. Whenever we're doing visits in different trusts, looking at the educational experience, trainees may use that opportunity to bring forward concerns directly with our visiting teams. And again, we will feed those concerns back to the trusts and ask for those concerns to be evaluated to see whether they're genuine, and if they are genuine, to actually address them. We will also have trainees who will bring forward concerns about undermining. Sometimes it's by more senior doctors, sometimes it's by other professionals, for example, midwives or nurses, managers, could even be by patients. So we do get a variety of those concerns raised with us as well, and again we will work with the trusts to get those investigated, managed and dealt with. So we will listen and take those concerns back to the trust. It has to go back to the trust for the undermining and the patient safety, because they have the data to analyse whether this is a common pattern or not, and also the employee, they're all employees of the trust. So we don't really have the knowledge of the internal systems, or the trainees are employees of the trust. They're consultants or their trainers are employer of the trust, so it actually has to be dealt with in the trust, but we will actually vigorously uphold the trainees' rights and support them.
I'm just conscious of time moving on, but it is an interesting point that you've raised. So my understanding is that the GMC have had somebody come to them, one of your trainees come to them and say, we've stumbled upon a serious issue here around that I believe is a problem with patient safety. GMC will then contact NIMDDA. NIMDDA will then begin working with the trust. Could I maybe just get a couple of examples from you as to what working with the trust actually looks like? What is that?
Okay, well, last year in the GMC survey, they divided the concerns up into immediate concerns and non-immediate concerns. We would have got an email from the GMC to tell us within 24 hours that there had been immediate concern raised. We would have had to go onto the GMC website, to a secure part of it, to find out what that concern was. We would have looked at the concern, and then I personally would have written to the medical director of the trust with that concern on that day or within 24 hours to ask them to look into it, and they had a very swift turnaround in terms of responding to that concern. We had to then look at the response to see whether the trust had actually recognised what the concern was, whether the action plan that they'd come up with actually addressed the concern and addressed it in a timely fashion. We had to make a judgment as to whether that response was satisfactory or not, and if it wasn't satisfactory, to go back to the trust and say that it wasn't satisfactory. And then we've had to report on all those concerns to the General Medical Council, who have also looked at them. They've had a response to concerns team, which analysed the responses from us and from the trust to see whether they consider them satisfactory, and will come back to us and ask questions as to whether, if they feel that the response has not been adequate.
Sure, I do appreciate your indulgence. Just very, very finally, obviously a trainee then finds themselves back into their post where they had raised the issue, and I suppose there is, and I know the Minister has done a lot to try and ensure that there are protections in place for whistleblowers, but there is still going to be, I suppose, an air of suspicion around this trainee by some of their superiors if they're seen to be, I suppose, a troublemaker, for want of a better word. What steps do NIMDDA have in place and safeguards to ensure that the training of that whistleblower is not adversely affected by what they have found themselves doing?
We have a whistleblowing and bullying policy. We have a learning and development agreement with each of the trusts. And within that learning development agreement, we require each trust to have a mechanism to deal with undermining and bullying of trainees. And if, for example, we find, if a trainee came to me and said that they were being undermined by their superior, we will go to the trust, and I have had meetings with medical directors over undermining, and we have got out and got the information as to who is responsible, and those people have been removed from training. From the training environment, and have no trainees working with them for a period of time, and we will very vigorously uphold the trainees' rights and support them and take it to the highest point in the organisation, if necessary, to get them addressed, because we won't tolerate undermining or bullying of trainees.
Thank you very much. Thank
I
you.
think we had one brief point.
I noticed in your submission, you said that some going through emergency medicine choose not to enter a training programme because it's more lucrative to do locums in various health and social care trusts. So you're saying our trusts who need these skilled trained employees to go through training programmes have perverse incentives which are stopping people training?
Correct.
What discussions has there been to remove such perverse incentives to ensure that there are the skilled training that is necessary?
Well, again, that's probably outside a true training remit, but obviously the departments are still being staffed, the services are still going on, and they're getting the staff from locum agencies, and the trainees or the junior doctors, because they're not actually trainees, will get more money from working for a locum agency than they will get from taking a training post. So there will be a number of trainees who will decide, I would like the flexibility of working as a locum for the next year so that I can work whenever I want to work rather than in a training programme. All right, I won't make progress along the training ladder, but maybe I want to do this for 6 months, a year or 2 years. I can earn more money that way. I can maybe pay for trips. I can take 3 months off and go to Australia if I want to, because it gives them that flexibility. So it's a lifestyle choice. I think it is harder to assess the quality of these doctors, because they could appear in one hospital today and another one tomorrow, or they could be doing it for a week or a month at a time and then decide, well, I want to go off for a holiday for a month. So it is down to their personal choice. We can't make them enter training programmes. I suppose the department have tried to make some progress by coming up with a locum agency or a arrangement for getting locums across all trusts with a standard rate of pay, and to try and cut the locum agencies out of it. And that maybe is one method that could be pursued more, so that there would remove some of the perverse incentive to work for locum agencies if they weren't getting that exorbitant rate of pay.
Thank you.
I'd ask you a different question, Professor Gardner. Are you a member of the BMA?
No.
You're not. Are any of the senior staff in NIMTA members of the BMA?
Oh, I expect there would be. I have been a member in the past, but I'm not currently a member.
And so could there be a conflict of interest? I mean, you with reverence, you keep mentioning those magical 3 words, the BMA, and you can quite see that they've got incredible power, and we know that. But, I mean, I keep saying the BMA tail is wagging the medical health service dog. I mean, I have to say that. I keep coming back to this, the BMA. But surely at the end of the day, we have to do what's not best for the BMA, but what's best for the people of Northern Ireland.
I agree with you.
Right. Well, run this past me. We spend almost £500,000 training these excellent medical staff, and we pay them between £40,000 and £80,000 in salaries. And they decide where they're going to go and what they're going to do. Now, put this, spin it on its head and go down to Knock to the police headquarters at Brooklyn, where you've got middle-grade police officers. One's based in Donaghadee. He says, I don't want to go down a skill. Well, they want to go to Hollywood or somewhere really north down, Bangor, right? I don't want to go down a skill because there's a much wider range of criminals in North Down. I can specialise in drug dealers or, shoplifters or whatever. Mr. Chief Constable, I would just prefer not to go. Meanwhile, there's a dire need for that middle-grade police officer in Enniskillen. What do you think the Chief Constable would say to him if he said that?
Well, I suppose you're working with an armed force and a much more, it's a completely different structure.
The Ulster Bank is exactly the same principle, middle grade manager.
Their employer then, the Ulster Bank is their employer.
Yeah.
Here the employer is in 6 months here, a year there. It's not, we don't have, there's not someone who's employing them for their 8 years of the programme.
But on a wider basis, and I know this is a trust issue rather than a NIMTA issue, but surely we must reach a stage that the doctors, whether trainees or middle grade or whatever, are sent wherever they're needed, and they go because society has invested so much money in them, and society is paying them jolly well for what they're doing. Because this is why Down Hospital is closing at the weekends, because we can't get the doctors to go, because they prefer to stay in the Royal, or they prefer to stay in the Ulster. Now, that is no way to run any health system, because the ultimate outcoming of that is that many of the small hospitals will close full stop as far as he's concerned. You know, that's where we're going.
Yeah. Well, I suppose if you're looking at if you want to deliver high quality care somewhere, you need a range of people working in that who can provide that high quality care 24 hours a day, 7 days a week.
Right.
How many places can you afford to have that consultant delivered care 24 hours, 7 days a week?
Then the logic of that is we have 4 hospitals with A&E in Northern Ireland. That's the logic of what you're saying. That we can concentrate on the big attractive hospitals, and we can't coax these people out of, they go beyond Kerry, Dufferin and Gormley, then we just simply close those services to communities.
I suppose it's down to the range of services and the quality of services that you want to provide, and where you can afford. It depends on how much money you want to invest. If you want to have high quality in multiple different sites, 24 hours a day, 7 days a week, then you're going to need many more highly trained consultants to work on those sites.
And we also need those consultants and middle grade doctors to go where they're needed, rather go where they want to go.
I think, Chair, you have to just reflect that we are in fact the training part of this. We only have access to the junior doctors, the doctors in training. We don't have access or budget or a very little sort of control over the people who would manage that service on multiple sites.
Yes, I accept that, but I think when they start training with NIMPNA, they should be given the contract. That's where it should be signed.
I mean, I suspect that none of us are going to necessarily be in disagreement with that. That's possibly an aspiration that needs to be considered. To come back to your analogy, I have no doubt that the PSNI contract of employment is such that the constable who doesn't like where he's being sent has a factor in his contract that says, sorry, yeah, I hear what you're saying, but that's where you're going. Obviously, we don't have that facility. I suspect the trusts don't have that facility either. So it's a much bigger issue than perhaps
just... Because the BMA would never accept it. End of the argument. BMA just would not run with it.
I think the BMA would oppose it and oppose it very strongly. But that's not to say that ultimately it could not be something that could be negotiated. I don't know. But it's a very, very big issue that would have to be subject to a fairly elongated, I would have thought, set of complex negotiations.
Just one final point. The Minister, by the way, is not coming to 4:15, folks, but we intend to have a short break before that.
Great.
Why do we pay locums less? You were saying this whole issue about locums. Do we not pay locums less than...
Did you pay locums less?
No, do we not?
Do you?
No.
No, I suppose we do not employ the locums in the first place. The service will employ the locums. We employ locums for training, which is the fixed term post. But
they paid less when they're training than if they were not locums.
That's right. They could pay less for their training.
Why is that? Why is that the case?
Well, I suppose often the locums are getting looked at for short term, unattractive, out of hours working in high press specialties, and if you want to get them working there, the trust will usually pay a premium.
Yep.
And the agency who employs them, who's acting as their agent, will actually get their cut out of it as well. So you're not only just paying the trainee, you're paying the agency, but the trainees will get more for working for an agency than they would for working for the trust.
Or for
directly.
taking the training post.
Mm-hmm.
Well, gentlemen and lady, Mr. Roberts, you didn't really get much of a look in there, unfortunately. I'm sure you're very concerned about it. But also,
I agree with everything that's been said.
Mr. Joynes, if you could emphasise that you had your arm in the sling before you came into the committee and not have to put it in afterwards, that we haven't been that rough on you, but I hope it all goes well for you. This is an issue that's going to run and run. And it's a mixture of responsibility between the universities, yourself, and the department, the trust. I know it's not entirely your issue, the fact that we're running into, time and time again, we're being told that essential services have been removed because we haven't got the staff to do it. But we really have to get our heads together and not have very nice, brand new, modern buildings vacated because we haven't got the staff to fill them. And the trusts have put a lot of money into really good buildings like Down and Enniskillen, and we have the new Children's Hospital coming in the Royal. And it's essential that we find some way of ensuring that we have adequate levels of trained staff to go into them. And I must say, when you go to public meetings in somewhere like Downpatrick or Lisburn, all the nuances of what's going on is rather missed on them. They just think they're being starved of essential staff, and their community is suffering, and they're going to have to travel into Greater Belfast or whatever. So I wish you well on this one, because it is a difficult one. That it's going to be one that will keep coming up. So I think, you might have been quite not a well-known organisation until a few months ago. I think your profile will rise up dramatically over the next few months and years. I don't know if that's a good thing or a bad thing. Is everybody happy enough? Right. Well, could we adjourn for, say, to past, and back for the Minister, which is another very important issue. Thank you. Thank you. Much appreciated.
Thank you.
Dr. Rob Findlay, remember, gave evidence last week, and someone was with him for lunch, and he's written up his experiences on a blog. He said my jokes were risky. I have to say, they might have been awful, but they weren't risky.
Sorry, was that risque or risky?
Well, I told the one about Doc and the whiskey, but I mean, that's not. Certainly. What? No, I would refute the fact that they were risky. They might just be awful. But apart from that, he's perfectly entitled to his point of view. Can we just still no white smoke? No. Can we look at Statutory Rule SR 2014-20, the Misuse of Drugs Designation Amendment Order Northern Ireland 2014? Could I refer members to page 19? The committee considered and approved the SL1 for this rule at its meeting on the 29th of January 2014. Are members content with the rule? Can I put the motion that the Committee for Health, Social Services and Public Safety has considered the Misuse of Drugs Designation Amendment Order Northern Ireland 2014 and has no objection to the rule? Agreed. Can then look at Statutory Rule SR 2014-21, the Misuse of Drugs Amendment Regulations Northern Ireland 2014, and could I refer members to page 27? The committee considered and approved the SL1 for this rule at its meeting on the 29th of January 2014. Are members content with the statutory rule?
Agreed.
If so, can I put the motion that the Committee for Health, Social Services and Public Safety has considered the Misuse of Drugs Amendment Regulations Northern Ireland 2014 and has no objection to the rule? Agreed. Can I then refer members to the Forward Work Programme, which is on page 35? And could I advise you that next week the committee will take evidence from the Public Health Agency and the Department on the issue around a public awareness campaign for ovarian cancer. And I think many of us would have had regular contact with Una Crudden on this very important issue, so I'm sure that Una will have an input to various members about that. So good to see that on the agenda. And then under matters arising, item 9.1 on page 39 is a response from the Minister regarding cervical cancer screening. Are members content to note and copy the response to Joe's Cervical Cancer Trust, who raised the matter with the committee?
Yeah, great.
Okay. Item 9.2 on page 41 is a response from the Minister regarding chronic fatigue syndrome facilities at Belfast City Hospital. Are members content to note and to copy the response to ME Support Northern Ireland, who raised this issue with the committee?
Great.
Correspondence, can I ask members to take note of item 10.1 on page 43? And then everyone happy? I'm keeping an eye on the door here. As soon as you give me the signal, I'll move into a different mode. Item 10.2 on page 47 is correspondence from the Committee of Finance and Personnel regarding its inquiry into flexible working in the public sector. The member is content that the Finance Committee approaches the department directly for information. I think that's self-evident. Could I ask members to note item 10.3 on page 51? Now, items 10.4 to 10.6 are on pages 56 to 58. Our requests from the Social Enterprise Northern Ireland, Cancer Search UK and Cancer Focus to attend the committee event on the 2nd of April. Are members content to invite those groups?
Great.
They're all well known to us all. And then can I ask members to note item 10.7, which is on page 59. Page 59. The only other item, well, we tend to run straight into the Minister's presentation, is that the next committee meeting is on the 19th of February 2014, starting at 2 p.m. in the Senate Chamber of Parliament buildings. I think it's a very appropriate venue for such an important committee. Any other business, folks? Anyone who wants to raise any issue before the Minister comes in? We'll be finishing immediately after the Minister's presentation and questions. Any burning issue? Everyone content? Right, well then, as I say, we're just literally waiting for the Minister, who no doubt is extremely busy. And oh yes, we're still in Canberra, folks, so no sign. Yeah, just one other issue. Anybody who's going to the NICON committee, I hope you've all, NICON conference in Le Mans, I hope you've all returned your forms. And let the clerk know when you can attend another day. Could I encourage people to try and go to at least one of the sessions, because it's the conference for health service professionals in Northern Ireland. It's the one opportunity you have to meet the complete range of representative bodies, statutory, charitable, departmental. It's only up in Le Mans, so you can hop up for a couple of hours. Right, we'll just have to... Sorry, Roy?
Clarify date time next meeting. Is it usual time, 2 o'clock next week? And is it room 29 or 30?
No, we'll be here.
It's in the Senate
It's
chamber.
here, yeah. So it's a rightful home. Before it gets sued by the other committees. I could see this going through to 6 tonight, quite easily.
You're buying your teas.
Yes, can we just adjourn so that we can switch off the recording? That's it, in case anybody says anything. Minister, you're very welcome. Your entourage needs absolutely no introduction. They're well known to us all. Michael, Andrew, David, you've been here many times before. You know the routine. Obviously, this is an issue that's extremely relevant to everybody around the table and to the community generally. So we welcome the fact that you've been able to come here and give us your view on the current situation. There will be questions, of course. There will be questions around various themes. We've tried to make best use, if possible, with the time that you have. Have you any, at your end, Minister, are there any limitations? None, right, so that helps us. The members have sort of dedicated themselves to being here as long as possible. So thank you very much. Could I just say that the chair is stranded in Londonderry, so can't make it, so that's why I'm here. So As usual, Minister, opening statement. We'll be very interested to hear what you have to say.
Okay, thank you, and I'll just make a brief statement. I'm grateful for the opportunity to speak to the committee members about important issues. Today I'm accompanied by Permanent Secretary Andrew McCormick, Chief Medical Officer Michael McBride, and I'd also have brought David Stewart with me today, the Medical Director of the RQIA. I think you've indicated, Chair, that most of you know David, but we'll have an opportunity to ask him questions at a later point, along with the rest of the team. When I was invited to today's evidence session, it was to talk about finance and A&E issues, and accordingly a briefing paper has been provided to you covering these issues. There have, of course, been some significant events in relation to our emergency departments since the briefing was provided to you. Of particular note, my statement in the Assembly on Monday afternoon and announcement of an independent review by RQIA into the major incident declared at the Royal Victoria Hospital last month. There has also been significant media coverage in relation to 5 deaths at the Royal Victoria Hospital Emergency Department, resulting in SAIs being reported. I want to take some time this afternoon to say a little bit on these issues, and then, of course, we will get into the questions. I hope you've all had a chance to consider and reflect on the statement that I made to the House on Monday. And if so, you'll be aware that I've asked David to lead an independent RQIA review into unscheduled care in the Belfast Trust, alongside expert assistance from outside of Northern Ireland. David was also involved in the inspection of the emergency department at the Royal over the weekend of the 31st of January, and I asked that he come along today as he is well placed to respond on the detail of any questions you might have in that specific context. I would caution the committee, however, that RQIA has not yet completed its inspection report, and it would be wrong to attempt to prejudge that in this meeting today. Members will know that RQIA inspection identified a range of issues which caused me to have serious concerns about whether the Belfast Trust is performing to the high standards that I, and more importantly, patients should expect. The inspector spoke to more than 100 staff across a range of roles and functions. The inspection has confirmed concerns about staffing levels in key areas, allegations of bullying, staff under intolerable pressure, and a system of care that does not function fully as it was set up to do. While these findings will rightly cause us serious concerns, I believe it's important that we all, as public representatives, act together to reassure the public that the Belfast Trust will continue to provide services in the RVH's emergency department to meet the needs of its population as a result of the commitment of all staff, and it is acting to manage the risks to safety that have been highlighted. Members should know that the Trust management team has responded with an open and fully transparent approach to RQIA's inspection and is working constructively with the Board, PHA and my department in moving forward solutions to these issues. I recognise fully the very difficult job the staff in our emergency departments deliver on a daily basis, and I want to express my fullest appreciation for them again, for their dedication and for their commitment to patients. As I said in my statement, the RQIA's wider review will report to me by June this year, and while its focus will be on the RVH as a province major trauma centre, undoubtedly there will be learning which can be of more benefit generally across the system. The review will therefore identify and recommend opportunities for all parts of the healthcare system to contribute to improving emergency care in Northern Ireland. It will look at how the whole system could remove some of the burden on emergency departments and also offer a much improved patient experience. Members will be aware that much attention has been given to the issue that 5 people died in circumstances where a delay in the emergency department might have been a contributing factor in those deaths. Although it would be premature at this stage to conclude that the outcome in these cases was related to waiting times, I think it is important to respond to these with deep concern and sympathy to those affected, and a clear and thoughtful perspective that recognises the reality that it is impossible to eliminate the risk of avoidable errors and failures. The HSCB has told me that 5 is the correct number for the relevant cases in relation to the RVH reported as SAIs during 2013. I have asked my officials to ascertain comparable data for other hospitals across Northern Ireland and any available comparable data for other jurisdictions. This will be confirmed and provided to the committee in due course. These issues are within the scope of the RQIA review. Members will know that I have made clear from my first day as Minister that the overriding objective for the entire health system is to protect and improve the quality of services we deliver. The health service must be safe, effective and totally focused on the patient. They are at the heart of everything that we do. And I want to emphasise to the committee that whilst these issues are ones that we have to grapple with, we cannot let ourselves be distracted from an overall health system that is improving in the care provided to people with strokes or in cardiac services, for example, and improving in waiting times. I hope that members will join me going forward in talking up, not talking down, the amazing National Health Service that we have. And while we absolutely have to be resolute in our recognition and response to address issues, such as those identified by inspections such as RQIA, we cannot let this take away from that. You will, I am sure, appreciate the context and focus of my opening remarks on our emergency departments and issues of concern, but I'd be happy to take questions on all issues that we're here to talk about today.
Thank you, Minister. I take it that your colleagues are quite happy that we go straight to questions.
Yep.
And the first set of questions are being led by David and Fergal. I'll let Fergal lead off and then David come in on the issue about the deaths.
Minister, like us, you've been saddened at the latest news. What we're hearing is sad for individual families, staff and those who find themselves in the front line in terms of medical provision. But I'm sure, like us, you must be very concerned at what we're hearing in terms of families not being told of the circumstances around their relatives' deaths, and now some further information that potentially the coroner has not been involved. I wonder, could you reflect on that?
Well, my understanding is that the Trust have procedures with the coroner in terms of reporting, and we can certainly seek to ascertain whether those procedures have been fully followed.
Do you not know at this stage if the coroner has been told?
Well, I can have it checked, and perhaps Michael can.
Yeah, I'm happy to provide some further detail to the knowledge and information that I have, that in 4 of the 5 cases, the cases contact has been made with the coroner, and the details of those cases have been discussed with the coroner. I mean, it's a matter for the coroner to determine in terms of whether a coroner's inquest is required or whether or not the death certificate can be issued that time. Well, I won't have that level of detail, Fergal, but I'm certainly very happy to ensure that we provide that.
Recently at the time of death?
Well, the coroner would be told at the time, well, this case would be discussed with the coroner at the time of the death, because if indeed there were reasons for discussing the case with the coroner, a medical certificate of cause of death cannot be issued until such times as the coroner is confirmed that he is content for same to issue. So that would be at the time. And obviously, I think it's also important to bear in mind that of the 5 cases that have been discussed, there are ongoing investigations in relation to 3 of those 5. So, as I say, in terms of whether or not there were delays which are material in terms of the outcome for the individual patient, we don't yet know, because the in-depth root cause analysis have not been completed in 3 of the 5, and 1 of those 3 is subject to independent review. So it would be premature at this stage to prejudge the outcome of that. Now, it may well be that in due course, if indeed there are other material issues which are identified, there may well be rationale and reason for further referring information or additional information to the coroner.
We understand that these are cases, obviously, of serious adverse incidents, and we understand too that some of the families have not been involved. How is that consistent with the coroner being told or not told?
Well, I mean, firstly, let me be clear in terms of serious adverse incident. Serious adverse incident system is largely there for us as a system of learning. Because a case is reported as a serious adverse incident, does not mean that something materially has gone wrong in terms of the individual's care, but indeed there may be cause for question as to whether the care has been provided to a satisfactory level and something that requires further investigation. Because primarily, the system is there to ensure that if there are any circumstances that require investigation, that those are investigated, that there's an appropriate degree of rigour in terms of that investigation at the appropriate level, and indeed that those cases are reported by the Trust to the Health and Social Care Board, who then directs the level of the incident, then directs the level of external input that there may be to the investigation, and then receives the report within a 12-week period. Now, our guidance as a department is quite clear on this. I'm not equivocal on this. Certainly, families, relatives should be informed both of 2 things. One,
At this point, the 2 families haven't been told.
the details that I have is that 3 families at this point in time have not been informed fully of all of the details. I don't have full and comprehensive
How do we
details
get a
of it.
learning process when families don't understand the circumstances of their relative's death?
Well, as I say, those are matters which we will be taking up, and indeed will have taken up with the Trust already. There clearly is matters which will be fully considered in the course of the RQI review as well.
You accept that?
Thinking all of this, Chairman, we need to be quite cautious, because we are talking about 5 people here, and 5 families, and we haven't been given authority by the families to talk about their cases in a public forum. And because of the small number of cases, it has the potential to be identified in the public. So I think we have to be very, very cautious in terms of the discussion that we have, that we do not infringe on people's privacy, which they may not wish to be discussed in a public forum. So I just exercise that word of caution.
I understand that and I respect that, Minister. But in 2 cases, the families don't know.
And can I answer the question
Can
again,
I ask the
which
Minister
is...
to respond to that, please?
I
In 2
think,
cases, the families don't know.
The Chief Medical Officer has already responded to you on that issue.
No, he hasn't.
He indicated that the circumstances...
Sorry, Minister. You said to this committee that you felt that we couldn't discuss the issues in this regard because there were issues of privacy. We don't know.
I said we
The
needed to be
families don't.
cautious.
Yes.
We have the potential of discussing in a public forum issues which families may not wish to be discussed in a public forum. Now that's something we need to be cautious about. What we can indicate is that there has been 5 serious adverse incidents reported. That may have been a contributory factor to a death, it may not. That is a matter for Mr. Stewart, Dr. Stewart, to investigate, and will report on that in due course, and will liaise with the families if that is the case. So that is the role of an independent report actually being asked for, an independent work being carried out, and that work will be carried out. But you're asking questions today which may infringe upon people's privacy.
Can I turn that analysis?
And that is something that you should always be cautious
Yes,
about.
obviously, I understand that. And can I turn your analysis around the other way and say that there are families out there who are now questioning whether they know something or not about the circumstance of the family's death, because there were far more people who presented to accident and emergency, and some of those people died. So there are people out there who don't know whether the waiting time contributed to their deaths. And my understanding is that some of those cases were particular conditions that needed treated urgently. So the waiting time was crucial.
Well, I think Dr. Stewart would be the person who would be best placed, perhaps, to indicate what his intentions would be on these matters in terms of getting to the nub of the issue and having appropriate engagement with family to inform them if there was issues surrounding their loved one's death that may have been a contributory factor.
But I understand that, but to be honest with you, I think we're following a pattern through on this in terms of information, and the information around potentially the coroner being told or not has come late in the day. The information about the deaths themselves has come very late in the day, and the information came 3 weeks after a statement that you made on the 13th of January, which was there was nothing basically to see here. I'm misquoting, but you know the point I'm making.
No,
there was only a spike.
I'd ask you to actually make your point with some more clarity than that, and not be putting words in my mouth that I didn't say.
Well, what you did, you said that there was no emergency issues in emergency departments, no crisis issues in emergency
Oh, right,
departments.
okay. I said there wasn't a crisis. That's a different matter.
Yeah. Do you accept now there is a crisis?
No, I don't accept there's a crisis. I accept that there was 5 people have died out of 80,000 attendances. There was others died as well. I accept that the treatment and care that those 5 people have may well have fallen short, and therefore we will have an appropriate investigation of that matter. 5 people dying in hospital of 80,000 being treated is not a crisis, and if it is a crisis, the entire UK hospital system is in crisis. So let's stop talking up problems here and trying to actually indicate that there's a crisis. We have issues and we have problems and we have pressures. I don't know whether you've ever been in an emergency department, Mr. McKinney.
I have.
And I don't know why you've been behind the scenes in an emergency department. But you could have someone who could come in who has been badly beaten up, could have been jumped on the street, might have had a few drinks in them. And that individual may have broken bones, may have concussion and needs care. You may have a series of elderly people who have urinary tract infections, who are dehydrated, who may well have respiratory illnesses. They're all needing care. On top of that, you may have cardiac incidents, you may have strokes, you may have major trauma, and you may get all of that in the space of an hour. So on some occasions, you will have to give priority to people, and others who require care may not be seen as often as you would like to do it. That is the nature of an emergency department. You can get it all at a short space of time. And we should stop damning our emergency departments, because they respond very, very well to people, and they provide excellent care to people. And if you'd like to look at the mortality rates, Mr. Chairman, for Northern Ireland hospitals versus the other hospitals across the United Kingdom, you will find that we fare better. So let's stop talking down our emergency departments.
I think it's important. I need to make a number of points here. One is, in every statement that I've made around this, and the SDLP has made around this, we've praised the staff. And in fact, even the training people that were in just ahead of you, we've made it very clear that we admire the enormous professionalism and endeavour that they have against the enormous stresses that they face. But the issue here, Mr. Chairman and Minister, is for us around how we learn about some of these things, when at the outset you were clearly playing down the incident itself, and that we only have now learned through information coming out from the professionals themselves to the media. We've only found out about these things. How does this service learn anything about improving if these details were not going to come out and have only come out through the media?
So I think there's a material point here, and I would have to take issue with this. These 5 incidents were reported as serious adverse incidents by the very trust that was providing the care. Again, just to re-emphasise the point that I made earlier, of those 5 cases, 3 of them are still undergoing investigation at this time. Thorough investigation, rigorous, I said serious adverse incidents, and the degree of scrutiny and rigour is basically ensured by the Health and Social Care at our Public Health Agency, are advised of those within 72 hours, and indeed the appropriate degree of scrutiny and independence is assured by the board and the agency, requiring the Trust's concern, in this case the Belfast Trust, to ensure that degree of independent scrutiny and rigorous examination. There's a requirement that those reports are made available to the board and the agency within a requisite timescale. The board and the agency then look at those reports and they identify learning. And if we do look at, this is an important point. If we take of those 5 cases, I said 3 of them are ongoing investigation, and as the Minister said, we don't yet know the full details or whether delays had a material impact here. What we do know, in terms of how the system learns, that 2 learning letters were issued in relation to 2 of those cases and disseminated in the system. So that's how the system learns. It learns by reporting incidents like this. It learns by investigating them thoroughly and rigorously. It learns by ensuring that that is rigorous and thorough, and it learns by disseminating that information. Our Health and Social Care Board regularly issue learning letters, they issue a newsletter, they provide regular updates to the department in relation to events. They seek to identify theme and emerging themes. Now, it may well be at a particular point in time you may not see a theme or a particular problem with one case that's undergoing investigation. It may be, and in the case of 2 of these where there was a learning incident, a letter issued, it was only when there was a second case in similar circumstances where the Health and Social Care Board, working with colleagues in the board and the agency, issued a learning letter to the system which said, A&E departments, be very aware of circumstances where patients present in this situation. Be sure to do the following. Make sure the following doesn't happen. That's how the system learns, and that's why the situation that the Minister has outlined doesn't occur, where individuals don't come in and perhaps, because they don't come in stamped on their forehead, I'm seriously ill, I'm confused, I've taken too much alcohol, I may have a subdural hematoma. They don't come in selected like that. That's why we have a triage system. That's why we need to make sure that we get to those patients and identify those most at risk. We've got to bear in mind people coming into our A&E departments are the sickest people who present to our healthcare system.
No, they're not.
Fergal,
No, they're not.
I'm sorry.
Could it order,
30%, up
could
to
it just-
30% of those
Fergal.
coming to A&E, Chair, do not need to
I
be
said
at
some
A&E.
of, sorry, with due respect, I have to say that, I have been working in health and social care for a long number of years. I have significant experience of working in an A&E department, of being responsible for an A&E department, and I have significant experience in terms of working within a department. So, with due respect,
Fergal, I'll let you back in. You've made some valid points, but I think we need to move on. I think David's come in next, and certainly if you want to raise anything, I'll guarantee you'll get back in. David.
All.
David.
I don't think he said all. He said they are the sickest people that come in, and they are the sickest people.
Could
say
all
all. He did
answers come
say
through
all.
the chair, please? Mr McElveen.
Thank you, Chair. I think we're possibly witnessing some of the confusion which has obviously resulted from this information coming out, and I think maybe some of it has been as a result of the way, perhaps, in which the information came out. And obviously, we did have a few sound bites on a very dramatic trailer for a television programme which has now been aired, and then there obviously have been other issues with other people speaking publicly. I wonder could maybe first of all, just to try and bring some clarity to that particular issue, when did you receive the information from the Belfast Trust about these 5 adverse incidents?
Me?
Perhaps Minister?
I didn't receive the information. And there are 400 serious adverse incidents, I understand, reported in Northern Ireland each year. So it isn't a practice to send those to the Minister.
And then within the department, though, of those 5 potential fatalities as a result of the delays, when did that information come forward, or how was that put out?
Yeah, we learned at the same time just recently, but as the Minister has explained, we don't receive the SAIs as such. They're reported and then dealt with in the way Michael described by the Health and Social Care Board and the PHA. In parallel, there is an obligation on the organisations, including the trusts, to send us early alerts where there are particular criteria met. And there's sometimes a question, to judge, do these cases or do they not meet that set of criteria? It isn't straightforward. In the 5 cases we're dealing with now, that isn't clear-cut, partly because, as Michael explained earlier, some of them are still under investigation and we don't know the circumstances. I think part of what has happened here is that a very specific question was asked, which was not and is not part of the routine collection of information. That is, tell me, as was asked, about deaths that result from delay in emergency departments. That was not a trend identified by the Health and Social Care Board in their scrutiny and analysis of all the SAIs through the year. That wasn't there. There were a number related to the departments being busy, but what has happened is the Trust conscientiously, in response to the questions that arose, started to look harder at a number of cases and found these, and then again openly and clearly, when they were asked again, told about them. And during the course of Monday, that information was clarified by the Trust. They've responded to public scrutiny in a very open and genuine way, in a way that was not inherently part of the ongoing system. So, with hindsight, maybe we could have been told something sooner. In real time, in the real world that people work in, people have behaved conscientiously and fairly, fulfilling their responsibilities. We'll need to look at this and see what other changes in procedure we need to adopt. And again, there's lessons that David and his team can pick up in the review. But that's the fact. We heard about these very recently, and we're now just looking to understand what lessons to draw out of that. Yeah. Do you want to come, David?
And just maybe to put this in context, in relation to the inspection we carried out, it was an inspection of the unit at a specific point in time. So we were going in there really to look at that unit to see what the circumstances on the ground were over that weekend period. We were advised that there had been serious adverse incidents, but not the detail of any of those serious adverse, or even when they had occurred. But that's an area for, if you like, looking after the inspection as to what the detail were, because we were in there really to get as clear a picture as possible as to what was actually happening at that point. At this point, I can say I have no information about the detail of any of these incidents, and I think the issues are emerging. But I would like to bring maybe a couple of factors that I'm aware of that may or may not be relevant in this situation. The first is that in the Belfast Trust, a very significant piece of work has been done in relation to previous studies and pieces of work that were done to establish a new system for monitoring all deaths in the hospital. And this really is a landmark piece of work, which I think in any UK setting I'm not aware of anyone has developed this, and a lot of people are interested. Every single death that occurs now to any patient in the Belfast Trust is now subject to an additional consultant's period of scrutiny. So the issues that you're quite rightly raising about deaths being reported to the coroner, if during that additional scrutiny, and this means a team of people looking at the death, considering the circumstance that led to death, looking at the evidence, before the system was in place, a death certificate could be issued by a junior doctor, and that may be still the case, but now that death will have been reviewed again afterwards. If there is a concern that the death should have been reported to the coroner, then a subsequent report to the coroner. The coroner has been in close, as I understand, liaison with the Trust about the process. So I think...
I have to, because Roy has indicated he wants to come into this specific point, and then I'm back to David, just on this specific as well.
On the issue of the deaths at the Royal, there has been ongoing delays at Royal's accident and emergency in terms of its 4-hour measurement over a number of years. Equally, there have been excessive waits, particularly at Antrim and Ulster, and that's also reflected in 12-hour waits and even 24-hour waits. So my question is, have there been other deaths identified through serious incidents where delays have been attributed at other hospitals throughout Northern Ireland?
We don't have that information now. That's an area the Minister said he's asked us to look at that. We're aware of some, but the information needs to be handled very carefully and very thoughtfully, because the numbers are very small, so there's a material issue in relation to breaching confidentiality, but that's an ongoing piece of work we're engaged in at the present time, which, as the Minister said, will be brought forward as soon as it's ready, but it needs to be done very thoughtfully. There'll be small numbers, but the issue here is to make sure that we're looking at them in a systematic and proper way, and it's actually highly complex. These are highly complex cases, and it's usually very difficult to establish was delay a factor, even if a delay happened. But what effect did that have? Those are often very uncertain. So yes, we're well aware of the general issue. It's one reason for having the time-based targets. They're intended to be a baseline, I suppose, that there's many cases that are and must be dealt with much more rapidly than 4 hours, and the clinicians judge that. We trust the clinicians to make the right judgments about what to do quickly, and as the Minister said, sometimes that's very pressurised because there's a whole lot of very urgent cases to deal with at once. Those things all are part of the day-to-day management, and we need to look at this with great thought and care before coming forward with any numbers.
I'm letting Fergal in on this one specific point and for one sentence, and then I'm back to David.
So just to be clear, your understanding is that there are more than the 5 that was revealed, that there are additional numbers of those?
Yes.
In Northern Ireland?
There are 5 at the Royal
as a result of waiting time?
Possibly. Again, just be clear that we're only looking at where waiting time may be a contributory factor.
Yeah, I think the important point, if I may, Chair, and just on Andrew's comment, if I may, I mean, I think it's about putting it into the context that the Minister was saying. So if we look at the Royal Victoria Hospital, you're talking about 80,000 attendees a year. If we look at across Northern Ireland, it's 700,000 attendances at our A&E departments, and I think it's within that context. And again, I'm happy. I kind of just finish the point.
I just get frustrated at this point, Judge. I need to come in here because I understand that people present themselves in substantial numbers to A&Es.
Yes,
but it's my father, my sister, my brother,
and I accept that as well. And all I would say to you again, and I understand the point, and it's a very valid point, and I hear what you're saying, and I hear the passion in your voice, and you've heard the passion in my voice in relation to my response. I think that some patients coming to our A&E departments are amongst the sickest patients that enter our healthcare system, because that is their front door for some of the sickest patients that we see. And you're absolutely correct, within that there are many other people who are less sick, and there is a question about whether that's the most appropriate use of our A&E service, and you know all the work that we're doing in relation to that. I'm sure we'll come on to that. I think that the point is that it's not straightforward to separate out those individuals in terms who need immediate care and attention from those who are less acutely unwell, and not in every circumstance. It's not readily apparent. The point I would make is that these are often very complex situations, and as Andrew was saying, it is often difficult to determine whether the length of time that someone is waiting to be triaged, the length of time somebody is waiting in relation to getting diagnostic tests, the length of time somebody is waiting until get appropriate treatment and care, or indeed waiting to get transferred into a ward environment. In those very complex situations, what material impact the delay in moving from one aspect of the care into another part of the system of care is had. And it isn't straightforward, Fergal, and I'm not seeking to smoke and mirrors here. It is complex, and that's why it's a piece of detailed and thoughtful work to ascertain whether or not...
Just to follow on from Mr McKinney, why out of thin air did this figure of 5 suddenly emerge in the media, which seemed very odd? It didn't seem to be planned, it just appeared, I think, through Tony Stevens.
As I said, my understanding is that the Belfast Trust were asked the question, and...
By who? Who asked
Spotlight.
By?
Directly by Spotlight. And the specific question put to them was deaths where delay may have been a contributing factor. That question was put, and it isn't part of our routine data collection.
That point was put to John Compton?
Yes.
Not the Trust?
It was first put to John, it was later put to the Trust. Yes.
Points, but I want to get back to David.
Yeah, Chair, I mean, that was kind of the point I was trying to get to, Andrew, in my initial question.
Yeah.
This has turned into trial by media. We're sitting here a week after this information came out, doing things the way that it should be done through the committee and through the mechanisms that are available to us. How did we get to a point where the announcement was made, a very senior clinician within the Belfast Trust announced 5 deaths, or the possibility of 5 deaths, on a morning radio show before the department knew? How did we get to that position? Because I think that has been a major contributing factor to a lot of the confusion that seems to now exist around this issue.
I would say this is because the Trust was genuinely responding to questions they were being asked and being, as we would expect them to be, open and responsive to inquiries. So that they, as we said earlier, the question was asked of John Compton when he was interviewed by Spotlight on Friday. The interviewer was aware of 2 cases, and that's the cases that Michael mentioned earlier, where there is a learning letter which shows the way in which those SAIs were handled and a response to that process, which was on a website. So that's a totally open process. These are 2 deaths that happened during the course of 2013, where there was a similarity of context to them. Therefore, learning was undertaken by PHA and HSEB, and a learning letter issued. So that's all in the public domain and known, and so therefore it was quite reasonable for the interviewer to ask John Compton about those in the interview on Friday. Then on Monday, Colm Donaghy was asked about those 2 same cases, and the supplementary question, it's exactly your question to me many times. What else have you not told me?
Yes.
So the interviewer asked Colm Donaghy, are there more cases? And Colm said what he said, you saw it last night.
Did they not advise you as Permanent Secretary before they made that statement?
Well, sorry, how can they advise me when they're in the middle of a media interview?
But I would have thought it was so significant, Andrew, that they would have.
They're going to say, stop interviewer, I need to phone the department first before I
think they were
start.
bounced.
No, it's not the real way.
Last time, Fergal, last time.
Just on that point, John Compton knew on Friday that this information was now going to be broadcast.
And
so did you have discussions
yes, we
over the
knew that on
weekend?
Friday. Yes, we knew that
you
on Friday.
knew that?
Yes.
And were there any other communications then with the Trust, between you and the Trust?
I had a conversation with Colin Donaghy on Tuesday morning.
What was the nature of that conversation?
Where he described to me what had happened in the interview he'd given to Spotlight. And we talked about it, and simultaneously then Tony had been asked to go on the Nolan Show, and he was asked the question, how could he not answer it?
Was he asked by the Nolan Show to go on, or did you
That's my understanding,
did
yes.
anybody ask him to go on in terms of immediate preparation for the event?
My understanding is that he was asked to go on.
Right.
And again, we are an open, responsive system. So Tony went on, did his very best to answer the questions. They had clearly thought through, they'd looked more carefully at the number of cases, and they'd looked at their, reviewed the recent SAIs, during the course of 2013, and identified 5 cases. That's them being
I do specifically on David's point, because I think this is at the nub of this, isn't it? And indeed, the risk is that we create a crisis of confidence, and indeed, I absolutely respect, Fergal, the legitimate questions that you're posing in that context, and indeed it's in seeking to understand the issue that we maintain confidence in the system or not in terms of the responses that are given. And I think that we need to have a system, and I think the system of trust is maintained through behaviours and actions, and following through on those in terms of what we say, in terms of what we actually do. And one of the important things that we need to absolutely ensure is that we have absolute openness and transparency in all our dealings with the public, certainly as public servants, all of us, and whether it's working within a department or whether it's working within a health service, are absolutely committed to that, and actually should follow that completely and absolutely. And then when you're asked a very direct question, then you have to answer that in an open and honest way, including where you don't know all of the circumstances. If you're asked a question, as we were asked today in relation to these deaths, the information that I have is that at this point, 3 of those deaths are still undergoing active investigation. 2 of them, the RCA remains outstanding in terms of completed, and I said 1 has now been subject to an independent review. So what we've done in the spirit, and the trust did, in the spirit of openness and transparency, is get that information out there. The corollary of that is that we need to respond and deal with that and manage that information in a mature and appropriate manner.
Until David's
And
finished.
Chair,
And that's your point.
I think I agree entirely with you, Michael, and I think from memory, Dr. Stevens' interview took place on Monday morning, and it's not the first issue that I've certainly noticed recently where there almost appears to be an internal battle, particularly within the BBC, as to who breaks the story. And it was well known that this programme was going to be broadcast on Tuesday night. Is there any suspicion that perhaps, for whatever reason, that a senior clinician may have been, I guess, got drawn in to what was actually an internal battle within the BBC?
I'm not in a position to comment on that, David. I think it's a legitimate question for you to ask. I'm really not competent to answer that.
But I suppose just from the point of view of when a clinician gets drawn into it, would that be something that would concern you if that was to have been the case?
We can't really speculate, but what is evident is that Spotlight had 2 SAIs and shouldn't have had them. Those were people's confidential information that they had hold of. So somebody give them that information, what's led to the questions and so forth. Now, if someone wished to and had particular concerns about the SAIs and that they felt that they weren't being dealt with appropriately, they could have brought them to this committee, they could have brought them to myself, they could have brought them to the Permanent Secretary, to the Chief Medical Officer, or others outside of the Royal Victoria Hospital, outside of the Belfast Trust. But for whatever reason, someone decided to give them to the media. And that was inappropriate.
Are you finished, David?
Just one final question,
President Gordon.
and perhaps we direct this one to the Minister. Obviously, some people may argue that the closure at Belfast City Hospital's accident emergency department didn't particularly help the pressures that we see at the minute. Would it be a fair challenge that a 3rd emergency department in the city, in the Belfast City area, would help alleviate the pressures that we're currently suffering?
All professional advice, and I haven't been picking anything up from the consultants, senior doctors, senior clinicians. that the Belfast City Hospital would have been something which would have helped us in these circumstances. The problem that we had with having 3 hospitals within the space of 2.5 miles of each other was that we had clinicians spread over 3 sites. Now, if you want to get people dealt with efficiently, and you also want to get them the best possible treatment, you want your junior doctors working on the same site as the senior consultants, so that whenever they need assistance, whenever they need advice, whenever they need help, whenever they actually need the consultant to see a person, that's available to them. So if you don't have the requisite number of doctors and clinicians on a site, you will only compound the problem that you have. I want to mention again the safety issue, because this is what this is all about, safety. And the mortality in the Belfast Trust is 99% of the mortality average in the UK. Now, that is less. The mortality in some of our other trusts are down into the low 80s. Now, the Belfast Trust obviously has a major trauma unit, and therefore will have the most serious illnesses, and therefore you would expect it to have the highest in Northern Ireland. But we're comparing our figures, and people are very good at comparing figures when it comes to 4-hour and 12-hour breaches. And it may well be the case, Mr. Chairman, that our staff in our emergency departments and in our hospitals are actually carrying out their work more thoroughly, which may deliver poor waiting times but deliver better outcomes, because we have better outcomes than the average across all of the English hospitals in our hospitals here in Northern Ireland. And that's the important message. I challenge the media to put that message out, that we actually have the lowest mortality rates against our lower mortality rates than the English hospitals, because that is a very, very important message that the public need to hear. Hospitals in Northern Ireland are performing safely.
Thank you, Minister. We're going to move on now to the theme of the RQIA's inspection over the weekend of the 31st of January. I think Mr. Stewart will probably want to come in on this, particularly issues like the allegations of bullying, and I'm going to ask Gordon Dunn to lead off on that.
Thanks, Chairman, and thank you very much, Minister, and for bringing your senior management in here today. I think we appreciate you coming here and addressing the committee. And I think we all appreciate the most difficult job you have in trying to manage the health service at this time. The RQIA carried out an inspection over the weekend of the 31st of January. David, and perhaps you could elaborate on that. Could you, first of all, give us some information on how you carried out that inspection or audit? I assume you had a team that went in there and looked at the various processes. And from my experience, I understand you would go and look probably at how they manage quality within the site and within the organisation. Perhaps you could give us some information on that. And I would be expecting you to look for trends that perhaps were identified previously. Was that the case? And perhaps you could add to that, please.
Yeah. I think that it may be helpful to the committee if I describe the process of this inspection. This inspection was not a review of all the, if you like, processes in the organisation. That will be an area that we'll be looking at in the longer term. This inspection was the type of inspection we would carry out in relation, say, to going into a nursing home or an independent hospital. We are sending a team in to actually look at the circumstances in the units at a point in time. We therefore want to engage with staff, we want to engage with patients or clients who are in the unit, but also we want to observe what is happening. So it's not a kind of a process that we ask for lots of information. It's not an audit, it is an actual inspection. Right. And maybe I should explain the background as well to this inspection. The Minister asked us, I think it was on the Wednesday of the week that we carried out the inspection, to carry out an inspection of 2 areas of the hospital. And I think in the debate and in the issues, a lot of the focus has been on one of those areas, perhaps less on the other area. The 2 areas that we were asked to carry out the inspection on have similar names, and I think that causes confusion in the system, and maybe the names of the consultants also may cause confusion. One area is the emergency department, the accident and emergency department, the front door of the hospital, and all of the members of the committee will be aware of that. But the second area is a unit called the acute medicine unit. And the acute medicine unit is staffed by consultants in acute medicine, so whereas the staff in the accident and emergency department are consultants in emergency medicine. So consultants in emergency medicine are trained in dealing with trauma, in dealing with immediate care of urgent conditions. Consultants in acute medicine, this is a new specialty, and it is looking at the urgent care of patients after they leave the A&E department who have medical conditions. So they don't look at patients with surgical conditions, they go off to the surgical teams, they look at the medical teams. So the concerns that had been raised with the Minister and this also with RQIA were relating to both of these units. And so the Minister asked us to do this inspection. The reason we were able to have the inspection carried out so quickly was that we have a team of inspectors who are currently carrying out inspections of all hospitals in Northern Ireland, all acute hospitals, looking at the experience of older people in acute wards. Now, that team is made up of experienced inspectors from two parts of our QIA. One part is relating to the team who would carry out hygiene inspections and looking at the environment and those issues. The other members of the team are a team who come from our nursing home inspectors, so they have long experience. This is a team that, although it was put together very quickly, was an extremely experienced team of people who have long history of carrying out a whole range of different types of inspections. So we looked at the two units. The intention was to use the tools broadly that we were using in the older people's review, but rapidly to expand the focus of those on the A&E department, so that we would focus as well. There are a number of processes in the inspection. One is really, if you like, standing back and observing what happens. So actually watching the processes, watching patients arrive, seeing what happens. Second one is to actually look at talk to staff and get their views as to what the circumstances are within the unit. And the next area is to look at some of the policies, procedures, and sometimes look at care records to see what's happening, and then also to talk, importantly, to people who are in the department at that time. Just to maybe put this in context, the Minister in his statement to the Assembly on Monday, as I recall it was Monday, very clearly has set out, although he has not yet had the preliminary report from us, and then there will be a further report, a final report, he has clearly set out, so everything in the Minister's statement, I think, is a very fair assessment of what we've told him. But I think I should maybe let the committee effectively know the experience that our inspectors had when they arrived in the department. We had planned this inspection would last one full day, and in addition... How many were in the team? Sorry, we had a team of, I think it was 8 to 9.
Between the two departments?
Yes, they were spread between the two departments. Now, the team... I can't remember the exact number, but it was in the order of 8 staff within. I joined the team then later in the process and went in and spoke to staff as well. But the original focus was to look at the service over that one day, and because accident emergency departments in particular, you can go into an accident emergency department at 10 in the morning and it looks perfectly calm. Everything is, there's very little, there's patients going everything, and you can go in 4 hours later and it's a completely different environment. So therefore we needed to be in for long enough to see what the situation was. So our plan was to also go in on Saturday afternoon and stay on into Saturday evening. What happened when the inspectors arrived, and I think I have to say, in the experience of our inspectors, they would describe this as, have long experience, has never been the situation. Large numbers of staff wish to engage, if you like, with our inspection team and really describe their experiences and also bring ideas in relation to how they felt the service could be improved. So in effect, we then expanded the inspection over 4 days than the original time, and therefore we were in the unit, say, I think it was to 2 a.m. on the Saturday, we were in on Sunday, and I was also in with the whole team on Monday. Large numbers of staff wished to speak to us. I have to say that we were extremely grateful. They were openness, they were transparent, but they described exactly their experiences. But the focus, while a lot of the focus is quite reasonably on the ED, the emergency department, I think it might be helpful. I'm conscious that I don't want to take too much time, but I think I'm conscious you need to be aware of the situation in the 3 departments. So I'm not going to go into detail, but I think they all relate to the situation, which I think that we need to look at very much in the context of the second phase of this work. In the emergency department, I observed, and I can give my personal observation because I was there and saw the situation, an extremely competent team of professionals at work who were managing a situation in relation to the ongoing admission of patients. They have very good process in place in terms of hourly review, and they get together, and I observed the process. They were going through the process, and it was clear to me that they were aware of the situation. Delegation to individual staff was excellent. But as we were in the department, they've had major issues, and they brought issues in relation to the 2 issues. I think one of the issues clearly is relating to the staffing levels, and that was clearly one of the issues that we brought to the attention of the Trust and then subsequently to the department. So there's an issue about staffing levels, but a very significant issue, which was very easy to observe as you were in the department, was that as patients were being assessed and cared for as you would expect by the emergency department team, and effectively the ED team, the emergency department team, had effectively finished their role in the patient, and the patient was due to be transferred out of the department. Those patients were not getting out of the department. And the numbers of people, so the people that we're talking about who are in trolleys, so patient flow issue, the patients in the trolleys are patients who have already been assessed and managed by the emergency department team. So this is really was an issue clearly, and we then went in to look at the situation, and we'd split the team. So one part of the team were, while that group were looking at the emergency department, another group were looking at the situation in the acute medical unit. And it was very clear that staff in that unit were also very significantly under pressure in relation to their staffing, the staffing that was available at that point in time. Again, I had the privilege of really observing the situation as to how that process was operating, and it became clear that a large number of patients were actually, who should have been in that department, being cared for by the acute medical physicians, were actually now at other points all over the hospital. So we therefore decided to expand the inspection, and we visited quite a number of other locations of the hospital where, in fact, patients were being looked after who really should have been in the acute medical unit. Now, that brought immediate concerns to us because, in effect, if the acute medical physicians are out going around the hospital, they are not having the time that you would normally expect to manage the patients. It's taking longer periods. Patients are being treated in units which were not their original unit of intention. So we will report on the detail in relation to the individual units, but I think your point, Mr. Dunn, is exactly what I saw there. This was a major issue of patient flow through the system, and the whole system needs to be looked at as a system, because we were being told about patients who could have been discharged but they were still waiting, patients who could have been transferred who could have been waiting. So the front end is where the symptoms are seen in this situation most acutely, because they have the patients in the trolleys, but the solution, and one part of the solution has to be to get that flow really moving throughout the hospital.
Yeah, thank you. But you've touched on a point about staffing, and there in the report and the evidence that the Minister gave to us, there was mention about accusations of ballooning. Now, have you any evidence of that, and could you maybe just summarise briefly where it came from, or where the potential was?
The evidence that was brought to our attention was staff speaking directly to our inspectors. This is through a large process of engagement. We spoke to over 100 staff, and they raised concerns of what they described, and the word bullying was used to our staff on certainly a number of occasions.
Bullying by whom? No.
Well, they perceived the culture as bullying, and that the pressure was on to move really patients through the system, and that It wasn't about, if you like, an individual victimisation of an individual. This was about the fact there was enormous pressure being pressed on the system and the staff to actually move patients through the system.
To meet targets, perhaps, rather than...
Well, the word that targets were driving processes, that was certainly something that a number of staff brought to our attention.
From your experience, and obviously you have considerable experience in management quality systems and managing quality process, are you not somewhat alarmed that these issues are now coming up? And would our QAA not have been aware of this through their ongoing surveillance and their ongoing audits within the Royal, which obviously you have sight of, I would say, on a regular basis, or should have? And with these issues, I take it you meet with management in relation to quality of care and quality of patients and quality matters generally. Have these issues been flagged up to our QAA by the management within the Royal in relation to the A&E?
The specific issues that relate to this flow of emergency patients at this point in time has not been brought to our attention, other than in the but we have been in, we've done hygiene inspections, we've seen improvements in hygiene, we have staff who've been on the ground. I think our staff who've been in that hospital before were really, I think, taken aback by the situation which they saw. They would not have described to us in our previous work, and that in fact so many patients were actually not in the area of the hospital. I think therefore we have to put this in context of why was this situation found on the day of this inspection. And I think that is a very critical point, that we understand that what has happened to the flow of patients in this hospital, because this is not in all aspects of the hospital. I think it relates to some specific areas of the hospital, and it clearly is extremely acute. And it's not something that solely is happening over the last month. We had an excellent presentation that was shared with us as we were going around, not given the presentation, but just given the slides, which showed that it is November. There was already indications that there were issues, but we need to understand what has led to the situation. But I have to say, we were not aware of the issues. We've had the information in relation to mortality, we've had information in relation to our hygiene.
I think the obvious question would be that, I mean, surely you should have done audits like this before, and you should have been aware.
And sure, the other thing, sorry, Chair, there'd be internal audits going on, and I've talked to staff in the Royal that are sick, sore and tired of doing audits. Audits. And what happens to those audits? Are those audits not fed through to management? Is there not a management review? Is there not a structure looking at these? And are there not corrective actions taken as a result of these audits? Because clearly they haven't been. If you're going in now and you haven't even carried out an audit yet, all you have done is done some surveillance, you've had a visit, but you haven't done an audit as such. When you go in and carry out an audit and look at these reports, could it well be the case that the evidence is there, already there, and it's been flagged up by staff through to management, and corrective action hasn't been taken? And if that is the case, I think it's serious. And it's not. How long have we heard about bed blocking within the hospitals? How long has that been going on? It's a very old cliche, long before ever I was on this health committee, and youth health professionals are aware of it. And are we back to that? Are we back to bed blocking within our hospitals, and the knock-on, the bottleneck is back in A&E? Is that part of it? Because if it is, these issues need to be addressed straight through. And we look forward to your report, by the way, David, when it comes forward. When is it likely to come forward?
Well, the report will be in June, but if I can advise the committee that
the short one, not the
no, the short one, it will come through by the end of this week to the Minister in relation. But it will be really, I think, describing the situation. I think your question is absolutely hitting effect what I think is the critical area we need to look at this.
We need to look at the process.
It needs, exactly. No, my experience in this, and I have to say, is much more really, I suppose, from my previous role, in fact, previous roles in relation to jobs in public health, and originally as a junior doctor a long time ago. And what we have seen over a long period of time is there have been periods of intense pressure in the system. In my experience, they're coming in a frequency of around 10 years. And the symptoms that you're describing are exactly the symptoms. People on trolleys,
Yeah.
delays in processes, bottlenecks. And we did, in the 80s, the 1980s, this is a problem, I have to be honest, I have wrestled with for some 25 years. And at times, I think we've got it to a situation where the situation is actually effectively, it will never be fully controlled, but it is under a state of control. It's a situation that's specifically difficult in the Belfast area. That's not to undermine problems in individual hospitals outside the Belfast area, but because it is a balance of the flows of patients that come into Belfast from other parts of Northern Ireland, in particular when other hospitals are in difficulty. So more patients tend to come in the system. At the same time, that has to be balanced by the flow of patients through the hospitals. So it is a really complex issue. There won't be a simple solution.
You should be a politician, because for the third time, you've actually avoided answering the specific question. Should the RQI not have been on top of this? You've explained a lot of the background, but the basic question is, surely you're carrying out inspections, you're carrying out reports. Should you not have been aware and on top of this before this latest issue?
Well, in the context of the immediate situation in the last month, we were not aware of the situation in the hospital, and we have not carried out. We have a small team of inspectors who do hygiene inspections across Northern Ireland in relation. We do not have continuous inspection processes. We carry out reviews. We carried out a review of hospital at night about 18 months ago. We were in every hospital. What I think the message that is absolutely reasonable, we do not have people on the ground in the units, so we are relying on really information but the specific area of concern that I really felt was that this was it's been an issue that has been growing in this hospital, but it has had very specific problems in the last 4 to 6 weeks.
Can I bring Michael in on this?
Just very, very briefly, Gordon, you're absolutely right. The fundamental responsibility is within the system of accountability within an organisation. It's the organisation's responsibility to ensure that it has systems and processes to carry out the very audits that we've been describing, to identify where there's areas that may be problematic, and action. Critically important in terms of 2 important points here: using patient information in terms of the experience of patients of our services, and actually what staff are telling us about surveys. And that's why we have staff surveys. And indeed, it's crucially important that we listen to those who use our services and those who are working in our services. That primarily, first and foremost, the responsibility for organisations providing that care. And there we get the added assurance from RQIA by carrying out their series of thematic inspections and reviews, or in cases like this where the Minister directs them to carry out a specific piece of work.
I think, Chair, just from my experience, what you're doing is really just doing inspections. What you need to be looking at is system audits. You need to be going in and auditing systems and processes and procedures, and following up on that through the management structures. So I think you need to move away. There's limited value in going in and carrying out an inspection to see if someone has washed their hands, or soaps are there, and soaps are. That's limited value.
That's the department's responsibility rather than.
Thanks, Chair.
Chair, if I could just respond to something that Mr. Dunn raised. He asked a question about bed blocking, and I think that is still an issue, that is still a problem, and that is something that I will look to this report to be very aggressive in ensuring that we minimise that activity. And I also think it is absolutely critically important, because the people who staff from the emergency department who directly spoke to me would have indicated that one of the biggest issues that they had was getting a ward to accept the person that they needed out of the emergency department, and they perceived that it should go to a certain particular ward. And the consultant in that ward and the specialist in that ward was saying, no, that's not my specialism because of the following. So they were getting lots of people who were capable of telling them why it wasn't their specialism, and what they really needed was to actually have the person attributed to a specialist for further care and treatment. And again, that's something that is going to be absolutely critical in the work that is done here, to identify that when the emergency departments, who are the most generalists that actually exist in the hospital now, identify someone to a particular part of the hospital, that they need support in having that person attributed to that part of the hospital.
Ladies and gentlemen, first of all, I'm withdrawing my estimate of completion at 6 o'clock. I'm now looking for supplementaries to Gordon's question, but I'm not going to give priority to Roy or Fergal because they've had him before. Is there anybody else ahead of Roy and Fergal who want to come in on this? Right, we'll go to Roy and then we'll go to Fergal. Right.
Can we just clarify what took RQIA in the first place?
Yeah, well, the request to go into the department was a direct request from the Minister, but we had received a letter from a group of consultants, not in the ED, from the acute medical unit, on the day before that request, or 2 days, I think, maybe before that request, which we had immediately forwarded really to the department, to the Health and Social Care Board and to the Trust. That letter related not to the emergency department but to the acute medical unit, and it related to concerns in relation to staffing and concerns in relation to the tracking of patients, which I think when we saw the situation where patients were at a range of locations across the hospital, we could understand really where that particular concern was.
You mentioned that staff were very open and willing to talk to you and wanted to talk to you, and that is quite unusual in any organisation, that you will talk to outsiders. Do you get a sense, is that because they felt their own management weren't listening to them?
Well, I think some staff said they had raised concerns and that the issues weren't being, but I think it was, and it's not possible to give an absolute situation, but I think some of it was about the intensity of the pressures which they felt they were and were observed to be experiencing at that point in time, and they felt that RQA would be a vehicle to allow them to actually bring those concerns to a group of staff. The lead for this inspection was a nurse who had a long experience inspector, but previous to that was a sister in an A&E department. So they were discussing their concerns with people who actually understood the nature of the concern.
Finally then, in the Minister's statement, when he was reflecting on the information he'd received from yourselves, the Minister said it appears that concern about the 12-hour and 4-hour targets for emergency care may have led some unacceptable behaviour by some staff on some occasions. Can you tell me what you found?
What we found was that staff perceived and told us that they felt they were being put under pressure at times to move patients out of the department at a period quite close to the 12-hour breach time, and that because of they was perceived as the need that target must be achieved, that was effectively forcing decisions really to be taken that patients could be moved out of the department. And I think they were telling us was that they had a strong sense of pressure those patients had to go, but at the same time they had other concerns in relation to the other patients who were in the department who had been there less than the 12 hours.
Did you come across any reports of misreporting of times?
There were the words like "stop the clock" and those kind of issues were used, yes, but we didn't go into a detailed analysis. But people said there have been times when they've been asked to stop the clock, or those times of terms were used.
Thank you.
Might be following that up at some stage. Fergal, one supplementary.
Yep. And could you reflect for me and compare what you found with what was being reflected publicly at the time?
Yeah, well, I think that's what and I'll do my best to give you my current analysis of what I think.
When I say publicly,
yeah.
I mean by the Trust of the Minister.
Yeah. Well, I think that what was being reflected after the event of the night when the hospital went on to they declared a major incident to bring in staff into the unit. I think that the perception that was being presented publicly, and I think I'm not giving any views to whether I think this was a reasonable perception, because at the point in time, actually very quickly, with the additional staff, patients had been moved into beds in the hospital. I think what I am seeing here is a lack of understanding in the whole system about the consequences of that night. And those consequences are very significant. And this goes back really to my previous experience when I was establishing the Emergency Mission Coordination Centre for Belfast, where we were working, so we had systems in place to coordinate the flows to deal with pressures in the system that we set up around, I think we started in 1999, and those, to build a system that would actually allow the whole system to, as Mr. Dunn said, if you like, smooth the flows in the system, understand the pressures. But from the perspective of getting patients into beds on that night out of the A&E department, that was a very major success in terms of actually opening up capacity. But from our experience, and I have to say I'm using experience, I don't want to give the impression I think that the situation in Belfast has changed dramatically since then. This will need some significant thinking to work out a solution, but I'm going to describe what my experience was over a period of about 5 years, when there is a phenomenon in the healthcare at that time, which I think is now clearly re-emerging, where there is a major impact on the system due to the Christmas-New Year period. That the Christmas-New Year period, in effect, is a period when the whole system operates in a different way, and we became clearly aware that over that 2-week period, hospitals, a lot of patients leave hospital over the Christmas period. So if you visit a relative in that period, you'll find very few beds often occupied in some wards. So a lot of beds are empty. Only major urgent cases are actually brought into the hospital, and lots of systems in the hospital are not operating at the normal capacity, such as X-ray departments. Because people are operating at the level. The situation then happens that once the first Monday in the new year occurs, on that day, a lot of patients are brought into the hospital. Not just the patients that we see moving in through the accident emergency department, but all the other departments, such as surgery and elective medicine, and everyone brings patients in over a very short period of time. So on the Monday, there generally are a lot of beds available in the hospital, but as more patients come into the hospital by Tuesday, or Tuesday, Wednesday, effectively the hospital is filling up with patients very quickly, and it's back to, I think, Mr. Dunn's comment of knowing the flows of the situation. There are very few patients who are being discharged, so the pressure builds up. This leads to situations across different hospitals, and but what happens is that situation is very clearly then seen to be resolved because patients are got into beds.
David, the record for a committee meeting is 8:10, which I endured 2 weeks ago, and I don't want to try and breach that record. And we've only got 2 sections done, and we've a lot to go. Though the next set of questions is related, they're from Mickey Brady, and on the issue. I think we're going to have to, because I think there's going to be opportunities to at this next set of questions to finish off. It's the RQIA external review of emergency care at the Belfast Trust in the wider regional context. So I'll ask Mickey to lead off on that.
I would say initially, Minister, you have accepted, or you have said that you didn't accept there was a crisis. I think you would accept that there are recurring problems, and I think those have been dealt with in terms of the systems, and obviously need to be addressed and addressed urgently. In terms of the RQA review of emergency care in Belfast Trust, it's going into a regional context. How will that involve A&Es in other areas outside Belfast? Also, will it involve the A&E at the Mater Hospital in Belfast? Another question would be, what would be the difference between this and the A&E Improvement Action Group? Because we've had evidence from Mary Hines on a couple of occasions before, who is specifically tasked to deal with some of their problems, I think specifically at that time in the Antrim Hospital. So it seems to be that these problems are recurring over and over again, and maybe that leads to crisis, because the 8th of January, as far as I'm aware, was a Wednesday. It was midweek, it wasn't at weekends, when you'd expect it presumably to be less busy. And the reason I'm asking about the regional aspect is there are busy A&Es, for instance Daisy Hill, would be a busy A&E. I think 2 years ago, with something like 35,000 to 36,000 people through in a year. So those are busy. And, you know, if you're looking at the Royal specifically because of recurring problems, then, you know, I'm just wondering, are other A&Es going to be involved in that? And what is the difference between the Mary Hines Group and what RQIA will be doing in this instance?
Well, I think in terms of what we want to do in this instance, the course of work will be specific to the Royal in the first instance. However, the pressure, and I recognise that it is a highly pressured situation. EDs are inevitably highly pressured, and that is something which occurs over and over again. I think probably where we are at this moment in time is that the constancy of pressure that they're feeling is taking its toll and putting probably greater degrees of pressure on staff than ever before. Now, I have a concern for the welfare of our staff, because if our staff are not performing to their best, then that has an impact on the quality of care. So, in the first instance that was raised with me was that staff were feeling under so much pressure that it was having an impact upon them. So, what I want the RQIA to do in the first instance is to look at the Royal, to look at the practices that are being adopted, to look at how we can get people into the ward settings more quickly, how we can ensure that the discharges that are taking place appropriately. We are in the privileged position of having health and social care trusts, and therefore I don't accept that bed blocking should be something that is that should be commonplace. On occasions it may be difficult to find alternatives for individuals, but we should be in a much better position to ensure that people actually are transferred elsewhere whenever they are no longer appropriate patients for hospital. So in all of that, I think we look at best practice in the Royal, and then where that best practice isn't being instituted elsewhere, we will want to assist other trusts, or indeed other hospitals within the Belfast Trust, to achieve that as well.
Chair, just to expedite matters, because I was going to ask you about a couple of other questions later. And you've mentioned, and you have yourself brought up the point about dealing aggressively with the bed blocking and the social care aspect of it. Now, there is an opportunity within the context of TYC of actually putting into place a situation or an infrastructure where people won't have to stay in hospital. I mean, the previous chair, Sue Ramsey, had quoted an example last year of a woman being in the Royal for almost a year because her adaptations hadn't been done to her house. So there's overarching issues that need to be addressed there. And I think, and just the other question I had asked was about the Mary Hines, the A&E Improvement Action Group. What is the difference? Will there be a substantial, I'm not saying necessarily improvement. The other point I would make is I don't think anybody is putting down staff. I think staff do a very, very difficult job in difficult circumstances, often faced with life and death issues, and I mean, we have the discussion in front of us. It's the systems that seem to be failing the staff. The staff aren't failing the systems, and I think that's the important point. And I think, you know, in talking to staff, certainly in my local hospital, the systems don't always come up to the same standards as the staff, and maybe its management needs to take some responsibility, because staff are doing a very difficult job and doing it very well in the vast majority of cases.
Yeah, I think on that last point, it's important that we understand that whenever criticism is levelled at a particular service, that very often individuals who are providing that service do feel demotivated as a result of it. I know from experience of talking to staff, long before I was Health Minister, that a lot of the stuff that ends up in the media, a lot of the criticism, and a lot of the very often unwarranted, ill-informed criticism, was demoralising for members of staff. So there is an aspect to it that we do need to be careful. And I was talking to, Tuesday night, I was talking to an emergency clinician who says all of this has been bad for emergency care. This was an emergency department consultant. He says, all of this has been bad for emergency care, all of this publicity. We're trying to attract young people and young doctors to come into this. And he says, all of it is hugely damaging to us to do that and achieving that. So it's okay for media to grab a headline, and health will always be an easy touch for them, because we have 70,000 people dealing with millions of cases per year, and there will always be failings. So it's always an easy touch for the media, but there is very often a worse impact as a result of that. But I would trust that the staff, I think, did want attention to be brought to what they were doing. They did feel that they weren't being listened to as well by the management as they should have been, and consequently that's why we have asked David and the team to preside over this.
Can I just finish off on one point, because obviously transforming your care is a huge issue. Would you see possibly alternatives to A&E being available? I'm thinking in terms of integrated care centres. You know, because in some hospitals, certainly in my own hospital in Daisy Hill, the out of hours is in the hospital. So it takes the pressure off in many, because people are going to the hospital because it may be in their head, they have to go to a hospital. But if the out of hours is in the hospital, then they're dealt with in a different context. In that sense, they're not, you know, in A&E as such. But there seems to be an opportunity. But again, there's a time factor, because I'm sure the staff in the Royal aren't sitting thinking, well, TYC is going to change all this.
In 2 years, yeah.
You know, I mean, that's the reality, but it may be an opportunity to actually provide viable alternatives where people will have somewhere else that they can be seen to, and seen to properly in that sense.
We're really at the nub of the issue, and I think this is what David said about, you know, at the moment and for the last little while we've been looking at the symptom rather than the causes. And it is absolutely correct to say that basically, right across the United Kingdom and the Republic of Ireland, we have a system of care which is not currently aligned to meet the needs and the current needs of the population. The truth of the matter is there's been huge advances in medicine. If we look at advances in surgery, advances in anaesthetics, we do more day case surgery. If you look at, for instance, even at hip surgery, people used to spend 12 days in hospital recovering from hip surgery. It's now 8 days. They have more community rehabilitation. We have enablement programs, a range of issues. So our length of stay right across the system is much shorter, so therefore activity is much more intense. We have a third less beds in the system that we had a number of years ago right across the UK. We have a third more admissions to our A&E departments, and 2/3 of those are over 65 years of age. And the whole thrust in terms of the vision under TYC is actually realigning how we provide healthcare to meet the needs of the population here and today and into the future. And that will need us to redefine what is provided in A&E. I mean, A&E is seen almost a victim of its own success. Its brand, our emergency departments are a victim of their own success. And ED doesn't mean, A&E doesn't mean, always and everything. And unfortunately, too often it's used as a gateway. We need to have alternatives in terms of unscheduled care, as you've described, whether that's in terms of enhancing GP services, whether it's enhancing community care packages, alternatives, better diagnostics for GPs to support GPs to manage people with long-term conditions in their home, rather than individuals arriving at our A&E departments. So I think you're absolutely correct. And then what we need to do in hand with that is to equip the workforce with the new skills and the new competencies that they're going to require in working in a range of different environments. And that's the vision within TYC. And we're on a journey. And that journey, we've started on that journey, and it will take some time to complete that journey. And it is a very fundamental and radical change. It's why we have 17 integrated care partnerships. It's why they're looking at pathways for the frail elderly, those with respiratory disease, those with diabetes. That is the direction that we are taking and steering the system, and that will take time.
Just briefly on the point about the IAG and the previous work. Yes. We've been on a journey for a long time to try and improve emergency care, and this review will build on some good work done by the IAG, which you've heard about in previous sessions with Mary and others. It was necessary last May to effectively focus that small team in the issues in the Northern Trust area. So that's where Mary and her team have been. And again, there's some significant progress there. By no means a total solution to the issues there, but significant progress. This is now similar themes. The Minister made very clear that the review will be informed by external support. So the issue in previous performance management and in the IAG and in this review involves establishing good practice and then checking that it's being applied in a very practical and straightforward way. So there are a range of known areas of good practice, and many of them actually relate to what we've just been talking about in terms of integrated care working, in terms of discharge, in terms of the different flows. The difficulty is not identifying what is good practice. Actually, the really difficult thing, the complex business of a culture of an organisation, is applying that good practice. So we're looking to appoint, in conjunction with RQIA, a number of external experts who will contribute to that process and help build on what has gone before. And in the meantime, the process of just monitoring and managing unscheduled care remains with the objective of ensuring high quality.
The only person in for supplementary is Sam, and then we'll move on to the next issue, which is Fergal.
Issues relating to emergency department staff and recruitment issues relating to accident emergency department staff. Why do we not recruit new super paramedics, as has happened in Wales and now in London? Surely this would help lessen the pressures on the A&E departments.
Well, an excellent question, and yes, we are looking at how, for instance, we can enhance the role. I mean, we have, at this present moment in time, I'll give you one example, and I think it was covered recently in the South Eastern Trust in relation to training of emergency nurse practitioners to work alongside GP out of hours in terms of providing services in the interim in Down and Lagan Valley Hospital. So that's an initiative by the South Eastern Trust. Similarly, we have emergency nurse practitioners in training within the Royal Victoria Hospital. So we are looking to enhance and expand the range of expertise, excellent expertise and experience that our cadre of nurses working in emergency medicine have, and also expanding that yet further. Now, obviously, we also need to give consideration to whether or not there's a role for physician's assistants, many models, for instance, which have been applied in the States and elsewhere. And I think those are all things which we're actively considering, and indeed there's examples of those being piloted here in Northern Ireland at this present moment in time.
I welcome your comments, but how soon are you moving? What's your time lag like?
Well,
even take Craigavon, for instance, which is my own constituency.
Well, as I say, I've outlined what's happening in the here and now. I'm certainly happy to provide further details of timescales for that work, or indeed other trusts which are actively looking at that. But I think that we certainly need to make absolutely certain, and indeed there's a piece within, and again, Mickey mentioned TYC around workforce development, and I mentioned about realigning the workforce to how we provide the care, and part of that will also about looking to see how we best ensure that we have the right people with the right skills providing care, and they're qualified and competent to do so. That will be enhanced rules for specialist nurses. It will be enhanced rules for others within A&E departments who are trained to fulfil other functions, working alongside as part of a team alongside doctors in training, working alongside other individuals who are at the consultant level within our ED departments. So again, happy to provide further detail on that.
I welcome that, Chairman. Sure. I welcome that, Minister. How soon are you going to let me know that it's all in and working?
Well, I think they are being piloted.
Yes,
no pressure, Sam. As ever, I think that obviously, I think there's always the risk that we rush to a solution or a particular model without actually piloting that. See that we firstly can we attract people to these roles? Are these roles actually going to assist in providing the sort of team-based care that's required? Will we be able to retain those people in those roles? Because retention into some new roles has always been a problem. My experience in the past as a medical director in a trust sometimes it's very easy to invent new roles and you can recruit and train people to them, but sometimes it's very, very difficult to retain individuals. And so I think we need to look at what's been taken forward in Wales and other parts of the United Kingdom, and also look at the... yes, absolutely. So I can't give you a specific time scale, Sam, but I'm happy to get back to you in terms of a good example.
6 months, I take it?
Well, certainly those pilots are underway at the moment and can give you the detail. I don't have the detail with me today, Sam, or I'll give it to you.
The Downs to start in March, all being well.
Could we move on then to the impact of other decisions? Fergal's playing the lead on this particular one, but I just, obviously, from my own personal interest, this is an issue that has come up in many parts of Northern Ireland. You've had Lagan Valley, you've had Down, you've had the City Hospital, and the accusation that is made when those decisions are made is going to place enormous strain on the services of the Royal. And each time the department, usually yourself, Michael or Andrew, said, oh, no, we have it all sorted out, we've it all monitored, we've built in access capacity. Now, there would be people out there who would say, well, we told you so, you're reaping the harvest, as it were, of decisions made elsewhere in Northern Ireland. That's me just setting the scene, and Fergal would want to lead on that issue.
Oh, yes, just before we get there, because part of our concern has been around decision-making and sometimes the public representation of that. So, Minister, on the 28th of January, you said that it came as news to you that there weren't an adequate number of middle-grade doctors to provide a safe service in and around the Down and Lagan Valley situation. And on the 14th of January, you said that the South Eastern Trust advised the situation had worsened over the previous 6 weeks due to the departure of 2 specialist doctors. They knew. Why didn't you know earlier? And why did they make a decision without informing you?
Well, they informed me, I think it was the week before Christmas, was whenever I picked up the information. Certainly, I had a meeting with the Trust Chief, with John Compton, with Andrew, my special advisor, on the Saturday morning before Christmas. And I think it was that week that we had learned of it. So that was the time frame for me being informed of it. I think that in that instance, the South Eastern Trust had attempted to keep something going, to keep the hospitals going, until it got to the point where it was clearly unsustainable. So they had, for the previous number of weekends, had consultants in the hospitals. There was no middle grades, there was consultants in the, well, there were some middle grades, but they were being supported by consultants, which ensured that the continuity existed. And the Lagan Valley has junior doctors, which the Down doesn't have. And in those instances, the consultants were working, I think it was 4 weekends out of 5. And it was indicated that that wasn't going to be something which was sustainable into the future. So they agreed to maintain it till early January and to get us over that difficult period. And that's what happened. I did contact the Chief Executive of Belfast Trust, and others have contacted the Chief Executive of Belfast Trust to indicate what the South Eastern Trust's intentions were. Because knowing the geography of the area, I anticipated that much of the work would end up with the Belfast Trust. They did take additional actions over their normal winter pressures to absorb additional people. So we hear in the Assembly, I think a number of Mr Brady's colleagues, for example, were referring to the 40-odd% of people who turn up at Ulster Hospital who are actually from the Belfast Trust. There is a considerable number of people who use the Belfast Trust from the South Eastern Trust area because it takes in Colin, Poldglass, so forth. And Lisburn people, if they weren't using the Lagan Valley, would look to the Royal before they looked to the Ulster. I was speaking to paramedics today who wanted to inform me of certain things, but they would indicate that all of the red light stuff that they would take to the Royal Victoria Hospital, because whenever you get a 999 call and it's red light or blue light rather, they have to take the person to the nearest hospital. So there is absolutely no doubt that the closure of Down and Lisburn or Lagan Valley hospitals would have an impact upon the other facilities. But the other facilities had been in discussion prior to that and would have indicated that they had taken actions to absorb the additional numbers. In fact, I'm not sure if you have the details of the numbers of people and so forth that were redeployed to do that.
Had you found out earlier, would you have made any other interventions to provide a different outcome?
Well, I can only make a politician should never make an intervention which goes against the advice on safety. So what I might desire and what I might want to do will always be tinged by, well, am I actually putting people in danger as a result of this? And I can't do the second thing.
Yes, I understand that point, and I appreciate that point. But you said that they were clearly able to manage it within a certain time frame and within a certain, if you like, safety spectrum. Was there anything that you could have done within that safety spectrum that could have provided a different outcome for Down and Lagan Valley?
Well, I think in the case of Down and Lagan Valley, this has been largely down to the recruitment of, in the main, middle grade doctors. And the fact that they did lose 2 doctors, and I don't think that they anticipated losing the 2 doctors in the autumn time, was part of the problem. They also had another locum doctor who was indicating, and he'd worked very hard all year, and it indicated that he wished to go back to his home country for a month in January. Led them to the point that it was very clear to them in January that there was 70 unfilled shifts, and consequently that would have caused a real danger to the people both in Lagan Valley Hospital and Down Hospital had they tried to proceed, and would have almost certainly led to a unplanned closure, which would have been a worse situation than what was proposed, albeit I am and remain profoundly unhappy that it happened in the first instance.
Should they have told you earlier?
Well, my view in all of these things is that the more information is shared, the more assistance can be given. So, yes, I think they should have told me earlier. I think that they were they were attempting to avert a situation. It may have been better had they informed us earlier, and I don't know whether we could have offered assistance or not, but at least we could have made some effort to help them.
But that decision impacted elsewhere.
Well, I think that it will have an impact. Now, all of the evidence, particularly relating to the 8th of January, and looking at the data, wouldn't indicate that it was additional numbers that it came from down in Lisburn that had caused the problem. I have previously quoted that there was 380 admissions to hospital on the same 3 days. The previous year there was 300 admissions to hospital. They would normally be admitting around 80 people per day to the hospital. So in spite of actually ramping things up to deal with the winter pressures, previous year that they had 300, this year they had 380 in the same period. I think that there are occasions that no matter what preparation that you make, there are occasions when you just can be overwhelmed with the amount of illness and sickness that can come your way. And they done the response that they done on the 8th of January, which dealt with that issue at that time. And it was an unprecedented pressure, without doubt.
But it wasn't a strategically positive decision. This was something that they did, and they pulled the plug, if you like, as a result of finding themselves into this scenario. And from a department and from a public health and a ministerial point of view, you were told at the end.
And it was neither strategic nor positive.
Are there any other supplementaries on this specific issue of outside hospitals? We are a long way from finishing. You'll be glad to hear, gentlemen. We're going to move on to the issue of recruitment of staff. We've had a useful session with NIMTA just before you came in, where obviously we went at this issue for quite a long time, so we don't want to repeat some of the points that were raised, but Kieran and Sam are leading off on this. So Kieran, can you, you happy enough?
I mean, the staffing has already been spoken about this afternoon, and on the Minister's report to the Assembly on Monday, he referred to and it's been referred to 100 staff across the range of roles and functions. Staffing levels in the key areas, allegations of bullying, staff under intolerable pressure, and system of care does not function fully as it was set up to do. That is shocking in anybody's book. And the Minister and the officials must be very concerned if that's the attitude. And let me put on record once again my admiration for the work that the frontline staff has done and continues to do, no doubt will do. But that's got to be a rhetoric now, a rhyme. We must ensure that what's happening there is finished and something new is put in its place, and those staff, dedicated staff, are supported 100%. Now, there's a number of questions here, but that's what is in my mind. At the programme last night, Declan Lawn, at the end of it, referred to a number of emails that had been prepared by consultants and staff and doctors concerned with this. Did you receive that, Minister, that email? I mean, you know, who did receive it and done nothing about it, obviously? And surely that's a damning report on, well, not the Minister himself, but the office and how it should have got to you.
I understand that the emails that was referred to in the programme were internal emails in the Belfast Trust. So clearly a consultancy is a problem, and they email management to identify the problem and wish that something is done about it. And that was the nature of the emails. So I don't believe even Michael would have received those emails either.
No.
Probably not HSCB. I would have imagined that they would have stayed within the Belfast Trust.
Here, remember, we're dealing with recruitment of staff, and
Yeah, well,
it's very tangential.
It is coming back to making sure that the staff that we have are treated properly. We heard in an earlier programme where staff, have you seen the staff actually crying? You know, you're nodding your head. That's wrong. That's shameful. Sorry?
Our team found staff who.
Well, I mean, you know, can you explain that? Why is that?
Well, maybe I can perhaps make comment on that. I think that the Minister has already referred to, and David in his feedback has referred to the severe stress that staff have felt under. And I think that, you know, again, as referred to earlier, I mean, for a moment we should not underestimate the passion and the commitment of staff, and I think none of us do, and I think we've all said that in the course of our discussions this afternoon, their absolute commitment, and indeed the sense of frustration which I think David was communicating from staff in terms of feeling that there were things that could be done, wanting to be part of fixing. But I mean, obviously, if you're a member of staff and you're experiencing that pressure and you're seeing the consequences of perhaps you've not been able to deliver the care as best you would wish to, that can be extremely distressing. You know, again, that's why we need to ensure that the immediate steps are taken, as the Trust are doing, in terms of the feedback that David has already provided, the detail of that in relation to when we get the substantive report, and indeed the further steps that will be required when we get the detail of the review and its recommendations in due course.
Was there any concerns of doctors, were they different from the nurses that you spoke to in relation to the A&E and the Royal?
I think what we saw was a team response. We felt this wasn't a doctors, nurses. It was a combined. The issues were commonly coming from both the doctors and the nurses. The doctors were clearly aware that the questions of the department were causing difficulties to the nurses. The nurses were clearly aware that the issues were causing problems to the doctors. But equally, what we also find is that the teams in the hospital and the AMU recognised their close relationship with the ones in A&E and the A&E equally. So it wasn't that there was there wasn't a divide between the doctors and nurses.
Well, what are the key obstacles preventing hospitals outside Belfast being able to recruit enough emergency doctors? You know, or what consideration have you given to changing doctors' contracts to require them to work on more than one hospital site, including rural areas? Is there anything that you're working on that would improve the situation along those lines, Michael?
Well, I mean, there's a number of levels to that. I think first to put this in the wider context, I mean, we must recognise that right across the United Kingdom, we have workforce issues in relation to emergency medicine. I mean, it's estimated across the UK something in the region of 50% of posts in emergency medicine are currently vacant. Now, we have to understand why that is, and I think you've perhaps had some sense of that even this afternoon, and you've heard some sense of it in terms of the Minister's statement, in terms of the pressure that staff feel under working in our accident and emergency departments. I think that, you know, for trainees experiencing that and working in that environment and being supervised in that environment, it doesn't actually inspire them with confidence in terms of pursuing a career in emergency medicine, even though it's a very rewarding career, because they see the pressures that their consultant colleagues are working under. And indeed, also we've discussed the external scrutiny and the pressures that they feel. I mean, I can think of no other area whereby the rapidity of decision making is as intensive as it is in our ED departments. doctors and nurses working in that environment have to make very rapid decisions and assessments, sometimes based on fairly limited information, and continually review that. And David's given a flavour of that process. So I think we need to look at how we make careers and future careers, certainly I can speak for doctors in emergency medicine, more attractive. We need to look about how we make the training programmes more attractive. And I think Keith may have explained to you earlier, and I'll not rehearse that again, in terms of giving them greater job security, making sure that they actually stay in emergency medicine and don't find working in other specialties more attractive than staying in emergency medicine.
Right. And finally, Mr. Chairman, did I hear someone say that there had been a recruitment of 8 new consultants very recently, where you were looking for 11, but 8 has been recruited? Is that right?
Well,
and the question is, if it is right, why is it only coming now? Because when we closed the city, we couldn't get sufficient people to staff it.
Well, I think very quickly, basically after the inspection, the Chief Executive of the Trust asked RQA, or really invited us 2 days later to describe the actions that were being planned and taken to deal with the issues we raised. So it was a very immediate response. What we learned in that conversation, there were in fact significant actions already being taken before this process to tackle these issues. So I think it's important that not to see that these actions were all in response to this inspection. The Trust had already advertised for a number of accident emergency consultants. They'd advertised for nurses for both AMU and, as I understand, for the A&E department, and they had a series of things. But what has happened, I think, is that the number of posts that they've been able to now, I don't know the outcome, but my understanding from what I was advised that they were hoping that 6 consultants would be able to be now appointed. And I think our immediate feedback was there are major pressures on staff, there are certain things that need to be done immediately, and I think it was very positive for us to see on the Friday, 2 days later, that a number of actions had already been taken to address those immediate issues, but that's not addressing necessarily this longer-term flow systems issues, which we have to really now tackle.
I mean, thanks for your information, but that, again, is contrary to what I'm led to believe. There was 11 of these positions were required. 8 has been recruited, and you're saying only 6?
Maybe I just try to put some clarity here. I think the figures here that we're quoting it's important to put it in the context. The College of Emergency Medicine has made recommendations in terms of securing optimal staffing levels in ED departments and indeed major trauma centres. Now that report was published some time ago. If we look at the situation, for instance, in England, the average number of consultants working in an AE department is 4.5 full-time equivalents. In terms of if we compare our numbers of consultants working in emergency medicine compared to other parts of Scotland, we do compare favourably, but there is absolutely no doubt that we need to increase the numbers of consultants and also the numbers of nursing staff, particularly in the Belfast Trust. And the aim should be, as the College of Emergency Medicine has indicated, to have 16 hours of consultant presence 7 days a week to ensure that we're providing those senior decision makers in terms of patients presenting. And for a major trauma centre, then that requires, and their recommendation in relation to as a major trauma centre would be that we should aim for an additional 11 posts to be appointed. Now, the difficulty is, if you even look at the Centre for Workforce Intelligence in England, they estimate that actually even to get to 10 full-time equivalents, which will give you 16 hours, 7 days a week, it's going to take in England to 2020, and to get to the cover that would require 24/7 in major A&E departments and trauma centres, it'll take to 2030. So the issue is a particularly pressing one right across the United Kingdom. The Belfast Trust clearly will seek to recruit the best calibre people that it can, but clearly there's an ongoing recruitment process. It can't appoint people that aren't appointable and they don't feel are suitable to fulfil the role. So there's an ongoing process. They can only appoint how many apply and how many they feel are able to appoint, and obviously they'll appoint as many as possible. I know they've had discussions with the Health and Social Care Board in terms of that particular aspect of workforce. And I know, and I think the important point, as David has indicated, the trust management team, and we've heard a lot about the trust management team, were in this space. They'd identified and had recognised that there were staffing issues in relation to both nursing and consultant medical staff, and were actively seeking to resolve that through the process, which they have now sought to accelerate and enhance the number, increase the number of staff that they're going to recruit.
I'm sure you'll agree that optimal numbers of staff by 2020 and 2030 isn't something which would be particularly acceptable. I have raised the issue with the Secretary of State, Theresa Villiers, who has written to Theresa May about our inability at this moment in time to recruit staff from countries outside of the European Union, because we traditionally had a good supply of doctors that came particularly from the Indian subcontinent, Singapore, Malaysia, places like that there, who were excellent doctors. And I think that we also need to be looking at why, for example, 25% of emergency doctors, emergency consultants in Australia happen to come from UK and Ireland. And the information is that they will have better working conditions and so forth. So we need to seek to address those issues, and that's part of the work that David will be doing. And for those doctors who have went to Australia, I believe that there is all sort of convoluted hoops for them to go through to actually come back and practice in UK again. So we need to be looking at how we can actually ensure that people who are very skilled, who have been practicing in other countries, who wish to come back and who would like to come back and work in their home country once again, that we actually facilitate them to do that as opposed to putting obstacles in their way.
Cian, have you finished?
That's fine.
Right. There's a couple of people have indicated, and I say we need to keep moving on, but I must ask the question I put to Nimta. Why can't we give doctors a contract that tells them where we want them and what to do? We're spending £500,000 to train them. We're paying them a very good salary. As I use the analogy of the police, you don't get police stations closing because there aren't enough sergeants. Sergeants are moved to where the need is. Can we get to a situation that doctors are forced by their contract and their generous pay to go where they're needed? Started for 10.
I think you'll find that there are considerably less or more police station closures than there has been ED closures in your constituency, Mr. Chairman. But in terms of it, it is much easier to recruit a police officer, and I know that others talked about teachers, than it is to recruit doctors. And that's the reality. There has been workforce changes that have taken place. We have now European working time directives that are applied. There is a whole complexity of things that lead us to the situation that we're in, and there isn't simple answers to it. But there has to be a series of steps that we can take which will mitigate against this.
I'm letting Fergal in last because he's had a very fair crack at it. Roy, do you want in on this very briefly? Just the two people, I think, and Gordon.
3 years ago, there was this problem of shortage of specialist staff in accident and emergency units. And we've been told that after 3 years, just before you've come in from the session we had with the training unit, that there's this new 2014 pilot, but we've been advised, unfortunately, this is not going to make much difference this year. So my question is, what is governments doing to engage with all the various royal colleges to ensure that changes do happen that meet the needs of this community? Because it's not enough for everybody to say we can't do anything. And one thing that came up during the earlier conversation was requiring perhaps and giving greater recognition to time spent to any doctor who does training in accident and emergency units, because it's very, very worthwhile training, and it's essential that we have them, particularly GPs at present. I understand is that they spend 6 months there. Can we not do other things to get middle grade capable doctors to provide assistance to the community?
Well, in response to that, Mr. Chairman, to Mr. Beggs, I think that, first of all, whilst the buck stops here, actually finding solutions to these issues and ensuring that our emergency departments are more attractive places to work in is not purely the responsibility of government. It is the responsibility of hospital management. It is also the responsibility of society. So it is for hospital management to ensure that the working conditions, that if people need to have more flexible working hours, that they need time off for training and all of those things, that they get the appropriate treatment for them. And we need to work very closely with our clinicians to ensure that we can do that. And that's one of the things that I believe is why Australia is proving more attractive to our emergency practitioners than perhaps UK or indeed Ireland. But society has to stand up and has to be very, very clear. First of all, it's unacceptable for people to abuse staff in emergency departments. But we'll all say it's unacceptable. But what will we do about it? What are we doing about the fact that our emergency departments at the weekend, 8 out of 10 people that are in there are people who are there as a consequence of consuming alcohol? And very many of those people will turn out to be aggressive. Now, if you're a young doctor and you've actually been in an ED for a while and you have the opportunity of doing orthopaedics, you have the opportunity of doing cardiac or something else, and you will be on call maybe one weekend in the month, or you're an ED doctor and you're doing it at least 2 or 3 times a month, and the people that the others are treating are saying, "Thank you very much, doctor, you've done so much for me, I really appreciate what you've sorted out," as opposed to someone who is effing and blinding them, being aggressive, potentially hitting them. Now, you understand where I'm coming from, that we as society need to ensure that our emergency departments are an attractive place, and we as a society should not be tolerating a lot of the things that are taking place, and we should be supporting initiatives to discourage and dissuade such things happening. So there's an element of that. There's an element of people who will turn up to emergency departments whenever people are already under pressure. And, you know, I've spoken to emergency practitioners that have said this. Saturday night, guy turns up. I've had a sore back for 3 weeks now. And then formed a complaint because he wasn't seen within 4 hours. Well, you know, there was lots of opportunities and other avenues for individuals like that there, and it goes back to the always and everything, and the pressure that's piled upon individuals, and people coming in and actually being cheeky with it. So there's a societal thing that we need to do about it as well, but the responsibility will still come back to us as to what we do, and that is to make the working conditions as positive as possible in terms of government for emergency practitioners. Emergency practitioners, unlike a lot of other parts of the profession, won't benefit much from private, and that is another issue, and I suppose we can't do much about that. But at the same time, many people who work in emergency medicine and will find that they get great enjoyment out of it and great satisfaction from the work that they do. And it is something that there's a buzz about, it's something that there's an excitement about. It is a place that you will go into that something different will happen almost every day, so it's not monotonous. So there is attractions as well, and that is why people are signing up to it. I should say that we have a very young cadre of emergency doctors now, and we have quite a number in training as well. So that element of it is not that bad if we can keep them. And it's incumbent upon us to ensure that we in Northern Ireland, because these people have decided to do emergency practitioners, it's absolutely critical that we actually keep them in Northern Ireland.
The point of my question is, we have very valiant staff working in very difficult positions, and how can you assure me that the health service, that the entire system, the management, consultants, the rest of the hospitals are all putting their shoulder to the wheel to help those in that front line who are under-resourced in terms of people with the necessary skills? That's my question. How do we really value them and show that they're valued, and make sure we work with them to help them so that more will remain there and assist the community?
You've indicated a very clear problem, and that is the entire hospital helping them and ensuring that they can get on with the work that they need to do in dealing with the emergencies that are coming in. And once they have done their course of work, at other elements of the hospital receive them, and that's going to be a critical part of the work that RKA have to do. But Michael, do you want to?
Yeah, I mean, there's so many aspects to this. I mean, Jimmy quite rightly mentioned working time directive, you mentioned New Deal, and some of the pressures, and Mickey mentioned that as well in terms of driving some of the hours that doctors can work. I mean, one of the problems that we had in the 90s when the New Deal came in and with the European Working Time Directive, where we had doctors in training working excessive hours, putting patients at risk and putting themselves at risk because of working to a state of exhaustion. So we have that issue, which is that doctors are working shorter hours, and that's a good thing because it's ultimately good for patients. It means better quality care. Similarly, we're having the demographic drivers, which we can't change in terms of an ageing population, sicker patients, more people, thank goodness, living longer, but more people living longer with more long-term conditions and all of the pressures that creates. We've indicated the need to move from the current model in terms of how we provide care, whether that's primary care, care in the community, whether it's acute care. We've outlined, the Minister's outlined in TYC, his vision for how we would take that forward. And if we look at, I mentioned earlier, what we need to do is we need to align the model of training and the skills that health professionals, doctors, nurses, social workers, and other allied health professionals will need to provide that future model of care. And I can speak certainly in terms of medicine. What we have done is we have now a very fundamental review of the future training of doctors, and the Greenaway review, the shape of training, which the Minister has met with the lead on that, which is currently with all of the administrations across the UK in terms of the future model of care. But you're absolutely right, that's the future. And what's about the here and now? How do we bridge this gap between transforming our services to the model that is fit for the needs of the population now and into the future? How do we bridge the gap between the current training model and the future training model and the skill set that we will need to be aligned with that? And the truth is, there are things which we can do. There are systems and processes that we need to look at in terms of flows through the system. Is there more that can be carried out in primary care through enhanced roles for GPs? Is there more resource and support that we can give for GPs, for community, in the community sector? Are there things that we can look at in terms of pathways, the integrated care partners, as I've mentioned before, looking at those who most frequently need our health and social care services, and looking at how we better coordinate those pathways and those flows so we get timely care to patients and keep them out of hospital. Because, if you're a frail elderly person, the last place you want to end up is in hospital. You need to, and the whole direction of transforming your care is to do that. And the Minister has outlined previously to the committee, and John Compton's been here discussing those pilots in those areas that we're working at. And then I think it's back to Sam's point. So we can look at all the systems and processes and looking at community care packages and how we manage long-term long-term conditions and how we provide that care differently. But also, let's also look at enhanced roles. Let's look at, is there a model whereby other individuals other than trained, experienced nurses and doctors who, through enhanced training and appropriate qualifications, can provide and support that role? So this is, and it's back to the line that the Minister used in his speech. If this was straightforward and easy, we'd have done it. It's highly complex. And every time you make a change in one part of the system, you create a series of other issues and challenges further down in the system. And I mean, the Belfast Trust is one example. They have been reviewing and improving their services across a wide range of areas, as David alluded to, in terms of acute surgical admissions and moving from a general medical take-in to a specialist medical take-in for the primary purpose of getting better, more timely care to patients. That's it's a journey that they're on. It's a journey that's not yet completed. And we're on a major journey of reform, both in terms of how we provide health services right across the UK and how we make sure we provide and train the future staff to work in that health service.
Folks, I think we've given this a fair airing. Now, there are three people who want to ask very brief questions, and we'll try to bounce through because we're moving on to waiting times with Pam, and that is an important issue. Sam, very briefly.
Very briefly. When I was a wee boy, and I'm still a wee boy, doctor surgeries, doctors come in on an evening, so many nights during the week, say from 6 o'clock to 7:30 or something like that. Could that be introduced again, or the doctors spoken to, because it would reduce the people running over to, say, Craigavon Hospital or any of the emergency hospitals. We'll just need stopped up or something seen to. But it would be encouraging, and I think while the doctors would be working, they'd be entitled to time off during the day, admittedly. But I think that was the old system, but I think some of it was good and should be considered again.
Well, I mean, I think there are many aspects of previous systems which worked well, and there are aspects of the previous system which didn't work well. I worked in the previous system. I'm getting old now, and I remember the previous system, and it wasn't a good place to work.
Is that the one I'm speaking of?
Well, I don't know, Sam, whether I was providing treatment and care to you or not, but certainly working as a junior doctor, training when I was training, working weekends, which started at 7 in the morning and ended at 6 p.m. on a Monday. That was not a good way to provide health care. It wasn't a safe way. That was hospital care.
Right.
Not a good way.
But
you're absolutely right. I think that, and we are in that space in terms of engaging with general practitioners, engaging with BMA and other organisations about models of care, and that is an active area that we are looking to, and it certainly is a very core component of TYC, yes.
It reduced visits to hospitals too, taking up time.
Yeah, we had a very useful session from the Medical and Dental Training Agency. Just to be brief, one issue was out of hours service. As I understand, there are no consultants available in out of hours service. Would it be cost effective to reintroduce consultants into the out of hours service and try and deal with some of these people that are ending up in A&Es?
Yeah, I think that's it's the right question. I'm not sure I have the answer to it.
Yeah,
I think that what you absolutely need is individuals who are senior decision makers with all the necessary expertise to make the right decision for an individual patient, and that's something that comes with years of experience. Certainly, also we need to bear in mind that we need to maximise the use of consultants' time. Because again, if you have a consultant who's perhaps resident in a hospital overnight, and indeed there's the number of attendants, and back to the point David made earlier, if the flows through the A&E department are such that it doesn't require a full-time consultant presence, then that's not a very effective use of their time, and that time could be better utilised during very busy periods. I mean, I think again I would go back to the College of Emergency Medicine report, which certainly was recommending that you should have at least 16 hours of consultant presence 24/7. And I think that's something which, right across the UK, we will struggle to deliver that comprehensively. I mean, certainly there are consultants available. I did pick up on one of the quotes in one of our media outlets, which was saying, not a consultant about the place. There are consultants about the place. After hours. I mean, we have consultants, if we talk about the Belfast Trust too, are there to 12 midnight, and we have them there at weekends, and they are about the place in terms of that they can be contacted and will come into the department and do come into the department when there's a need for them to come into the department and where they're called in. And we saw in the response to the major incident on the 8th of January, the commitment and dedication of staff who come in from home when the need requires. And in that respect, the escalation plans that were in place within the Trust worked well to make sure that key staff were available to meet the pressure and need at that time. But I think there is a question, how best and make most effective use of consultant time. And again, I suppose it's back to Sam's point. Is there a way of ensuring that you get that level of expertise through the right mix of staff of the right skill set? I don't think there's an easy answer to that.
Mm-hmm. Fergal?
Yes,
Thank you,
sorry, and can I just reflect back on what the Minister was saying? I don't think you give any argument here that society does need to take a look at all of this and how we behave and how we interact with staff and value people who are highly trained in what they do and want to do the best for you in terms of outcome. But some of what we've been talking about here is in terms of answer. And we had the training organisation in earlier on, and what they said was we'd be looking at a different answer if we understood the demand separately. So, for example, they were saying that because of the significant proportion of people who are presenting to A&E who shouldn't be there in the first place, then they might not need to be looking at training as many accident and emergency doctors, and they may have to put their focus on training elsewhere. So, what has been, I appreciate what you're saying about the future vision of how it all might work well. But what can you point to me as happening now, today, to satisfy what your training organisation says would make a significant difference to the problem?
Well, I suppose that's something which, at a UK level, I've been involved in for more years than I care to remember sometimes, which was, how do we reform medical training to ensure that we can absolutely... Well, it is the point, Fergal. It is the demand here and now, because we've been on this journey. I mean, for those of us who've been involved in it for a long number of years, I mean, we could have had this conversation, as Sam has reminded us, and indeed we did have this conversation in terms of how do we make sure that, 10 years ago we were having this conversation. 5 years ago, we were having this conversation in terms of modernising medical careers. We were having it in 2006 in terms of the whole MTAS recruitment exercise. So we've been trying to reform and ensure greater flexibility and ensure staff have the right skills on an ongoing basis.
Yes, I understand that. But we need more accident emergency doctors.
Yes.
Because more people are going to accident emergency.
Yes.
And many of them don't have to.
Indeed.
So therefore, just to look again, as Mickey said earlier, about co-location of
and that's what we're
different
doing.
kinds of front door. That's being looked at very actively, and there are different models emerging in different locations, because that can be site specific. But generally, to look at that as an option.
Ideally, we get to the point, Mr. Chairman, where you have an emergency department where the blue lights come into, and where a triage nurse actually says this person is ED, or actually says this person is minor injuries, or indeed this person is more chronic, and here is a GP. Now, essentially, that's what needs to be happening at the front doors of our hospitals.
Integrated care.
Now, that is happening at some of our facilities. So, for example, Craigavon Hospital will have an out-of-hours doctor, which is on the same site.
Yeah. How much analysis has been done of those who are presenting themselves to A&E who otherwise shouldn't be? And doesn't that feed back to things like 3-week and 4-week waiting lists for GPs? And doesn't it feed back to potentially consultant-led cancellations as well, which is something we've taken? So what analysis has been done on the length of GP waiting lists and how it's impacted?
Yeah. I mean, I think that's all been looked at. I mean, you quoted quite correctly a figure, earlier, which in terms of, there's been estimates that a third of individuals who attend A&E don't need to be in A&E at all. In terms of how much of that is related to, inability to access service through other routes, either through getting a timely appointment with their general practitioner, or whether it's basically their general practitioner has indicated to them, well, I need to refer you for a diagnostic test, and the GP can't get access into your diagnostic test, whether that's a chest X-ray or whether it's an ultrasound scan or whatever it might be. I think it's difficult to say, and I think in individual circumstances it will vary. The real problem here is what I said before: A&E is too accessible.
No, can I stop you there? I didn't ask you about whether it's acceptable or not. Has any analysis been done into it? To where if 30%?
Yes, Southern Trust have done that.
Yes, they have.
And what's it saying?
Well, I mean, again, I don't have the specific figures in front of me, but certainly we can provide that
No,
too.
I don't think it's a figures argument. Surely it's a strategic answer to that.
Well, the strategic answer is yes, that there are alternative pathways which are not currently in place that need to be in place as effective alternatives to individuals attending their A&E department. Now,
part of the task for the integrated care partnerships is to identify new pathways to take on board exactly the kind of analysis you're talking about. So that yes, that is a major piece of work. But we can't take it all on at once. So the ICPs have been given a remit in a number of specific areas, but it is in the realm of improving integration, of therefore ensuring that it's right place, right time, rather than people. You can't say people shouldn't go if that's where they choose to go. They've chosen to go for a certain reason. So we need to develop the alternatives, and that's what the ICPs are there to do.
They're choosing to go with respect, some of them, because Down and Lagan Valley will be closed. They're choosing to go potentially because they're not getting an appointment, and they're choosing to go because they can't get a front door. And the front door to the service is now the accident emergency unit.
I think there's a fair lot of reason to that argument. And I indicated that in terms of the minor injuries side, we can probably man that with an advanced emergency nurse practitioners, as opposed to doctors.
Yeah, but
what's actually eases the pressure on what the optimal figures are for what is currently used. Also we need to recognise that there's a reality there that Michael was an ED in the 1980s. Michael was in the ED in the 1980s, a completely different place where the gunshot wounds and the bombs and all was coming in. Now we have REDs which have an awful lot of elderly people coming in. Now, what more work can be done to actually avoid those elderly people coming into ED? If they need to be admitted to hospital, how much more can we do in terms of direct admissions as well? And that's something that the South Eastern Trust are particularly focused on now with the Down in Lisburn thing, Lagan Valley thing. So there's elements of work to be carried out there as well.
Yeah, and just a final comment. I know, Chair, but I think it's important when the Minister comes that he's given of his time. I think that this is important to try and extract as much from him, if you like.
12 hour wait, so it will keep going.
We won't go over the 4-hour time. But the problem is that things haven't been done to this point. Now the South Eastern Trust is putting in a plan against the backdrop of a non-strategic and not positive decision.
Yeah.
It can't get the emergency nurses because they're not trained, and the Lagan Valley won't get them for at least 10 months.
Well, Lagan Valley, the issue in Lagan Valley is the co-location of doctors. So in Down, the co-location of doctors happened some time ago, and they have willingly, the out-of-hours GPs are willingly serving that community and keeping the front door of the hospital open. They haven't got that position in the Lagan Valley, unfortunately, and the out-of-hours doctors at this moment in time haven't expressed a willingness to do that. So the South Eastern Trust have a course of work to do with the doctors and indeed the local commissioning group to make that happen. And were that to happen, I think we can get the emergency nurse practitioners. That is less of a problem. But what we do need to be doing is training more advanced emergency nurse practitioners who can take it a step further. Again, from whenever Michael was a doctor, what nurses done then and what nurses do now are dramatically different. And we haven't reached the end of that. No. There is still much more that nurses can do, and we need to extract that skill base and use that skill base even further.
Right, folks. We need to move on to the waiting times, to the 4 and 12 hour target, which we touched upon. We're just about to set the record for the longest inquisition of a minister, and so we really need to keep moving here. Pam, can you lead off on that?
Thank you, Chair, and thank you for your presentation. Apologies for putting my coat back on, but it's an attempt not to present at the A&E at Ulster because Gordon would be very displeased at that if I didn't stick tantrum. I didn't see the programme last night as I had a happier event to attend in that I was privileged to be present whilst the healthcare workers of the Antrim Borough were conferred the Freedom of the Borough last night, and I think that's testimony to what we do think of the whole medical profession, very wide-reaching, right down to pharmacists and community nurses and everybody. And I think it's a testimony of what appreciation we certainly have of them in our area. But as for the waiting times, targets of 4 hours and 12 hours, can I first of all ask how the policy of the 4 and 12 hour targets were arrived at?
Yes, I was around at the time when they were first introduced in Northern Ireland, which was back to 2006, and it was broadly read across from practice adopted across the rest of the UK. One important difference at that time was that the target for 4 hours in England was set at 98%, and following discussions with the clinicians in Northern Ireland, we adopted 95%, just recognising the reality that in practice there are a small number of cases, a small proportion where actually there's a need to await decisions and to monitor, and so it has to be, the targets have to be clinically informed, that they're responding to a public expectation about the fact that conditions in A&E need to be managed well, and so they were adopted broadly by reading across from England, but with some adaptations for the local context. And I think it was summer of 2006 they were introduced in Northern Ireland.
Okay, so what do you see as the strengths and weaknesses of those targets?
They have a clear signal that access time matters, and in terms of quality of care, that's very genuine, because as we've seen, there can be additional risk associated with time, but they are only one element of the important management of emergency departments. The clinicians know very well that there are a very significant range of outcome measures that are much more important clinically in dealing with the individual cases, and they are specific to the presenting condition. So in practice, there are a range of other indicators and measures that clinicians use. So time is one thing, but that has to be seen as a very basic, and actually in some sense quite a crude measure. That there has to be a much more sophisticated clinical management, and that is what is happening. It goes back to what the Minister said at the very beginning of this session. You're dealing with a range of different things happening all at once, and then judging very quickly how to intervene and how to triage. That's the day-to-day practice. So they have a role to play, but also significant limits. And also, I want to make a point that has come up with me a lot in relation to this issue. The targets are intended to be dealt with and handled at corporate level. They're targets for an organisation. Yeah. They're not. I don't think that actually frontline clinical staff should really be all that bothered about those targets. Their job is to look after their patients. Yes, they need to be doing it in a timely way because that's part of normal good practice. The actual achievement of the targets is an organisational thing, and the issues reflect differently. They depend, both targets, delivery of both targets depends on the whole system. It's impossible for an emergency department to deliver properly if the flow isn't right. So we can come back to the discussion earlier on flow. So very, very important that that's looked at a system level. And I think that we need to make sure that there is no sense of bad reflection to frontline staff in relation to targets. That's just should not be an issue at all. Furthermore, and this links into the discussion earlier on bullying and the signals, and it's a point of grave concern that anybody should be under undue pressure in relation to the significance of these waiting times. They have a significance. They're not unimportant, but no one should ever be asked to do the wrong thing to meet a target. That is absolutely wrong. That is not to be tolerated. The care of the patient has to come first, and that there should be no question about that. I think that sometimes the message gets lost in translation. The Minister explained in the Chamber that actually, yes, this is an attempt to fulfil an expectation. The targets have a validity in that sense, but if the message gets mixed up, if we're not focusing on quality of care, safety of care, patient experience, if those get lost in this process, then that's wrong, totally wrong, and we need to ensure a balanced message here.
And we do accept that there can be a rather crude measurement, but there was a reference earlier on that during the RQIA investigation in the Royal, there was mention of stop the clock. Now, crude and all they are, I think it's absolutely essential that there's no manipulation, deliberately or otherwise. So, I mean, if the staff are making those allegations and there's any truth in that, then that would be a very serious issue because, you know, whilst we can say they've got their imperfections, I don't think that the book should ever be cooked, as it were.
Absolutely. The objective is to deliver a good system, and that includes good flow management. And if no one should be, the issue is not to just achieve the numbers. It's to actually make the system work properly. And if false information is in there, then how can you tell? So therefore, it's just so important to give the right signals here to promote a culture where the focus is on doing the right thing. David, have a perspective.
Just very quickly, it's also important that the target is not seen as something that is okay, because the clinicians that we talk to want those patients out of the ED department, not at 4 hours. They want, once they have made their decision that the person needs to be admitted, the best system is that that patient will be admitted immediately on to the next stage. Yeah. Because what we're seeing and what we've seen in the hospital is if the patient spends too long in the ED department, they may not be moved up to bed, even though they were admitted into the hospital, say, at 2 in the afternoon, and don't get up to bed to, say, 6 o'clock or 8 o'clock in the evening. They then, vital systems that are tests and investigations that could have been done that afternoon for that patient may wait for the next day. So there was, they were not emphasising that 4 hours is better than 12 hours, but 4 hours is not really what you want a system where movement is immediate if at all possible.
I mean, it's harder to provide quality care and good experience of care the longer individuals are spending in A&E without being moved on to the appropriate ward area.
Now, we're going to move on to Roy. We're going to look at resources, money and staffing levels. Sorry, was there somebody Pam, had you another question? Sorry about that. I should have checked to see if you finished. Sorry.
After all my patience, I disappointed you. Yes, indeed, we all are. I mean, I've had very recent, very positive experience from A&E with a family member just within the last number of months. And it's actually in the new A&E in Antrim. And I can also say that the best of care was given, every precaution given. And we were there well over 4 hours, I'm sure maybe 5.5 hours. But it was absolutely for the right reason, where the doctors were being very cautious, very thorough, and leaving us and themselves with, absolutely positive that it was safe to go home, that everything was all right, and they had taken the right precautions and done all the tests, and were just ultra thorough. And there was no feeling of being rushed. Maybe I was in a very good day, but it was excellent. But what I do want to ask finally is, has there been any consideration given to altering the targets? And if there has, what way would you alter them?
Specifically, no. I think the sense is that it remains an important measure. I think the disappointment is the difficulty of achieving better performance against those what are in effect standards. That's a real long-term difficulty we're having. The large numbers of 12-hour breaches and the fact that our performance is materially poorer compared to the rest of the UK. That's disappointing. But I think we have to look at it in perspective and then try and secure systematic improvement. There's no particular revision of them underway at the moment, so that they're just seen as an element of a package of standards.
There should never be an exclusive means of measuring, how an ED is performing, and I know that there has been considerable work done in the South Eastern Trust to have a series of other measurements, which puts them in a very, very favourable position vis-à-vis other parts of the UK. You talk about changing the potential of looking at changing those standards. I know in the Republic of Ireland they have 6-hour standards and 9-hour standards, and their 6-hour standard, they had 60-some% of people being seen to within the 6 hours. Well, we have 80% being seen to within the 4 hours, so there's a considerably better standard that is being set here.
I mean, I think absolutely, as both Andrew and the Minister have said, there are other things that matter, and we are measuring those other things that matter. The truth of the matter is they are in trust quality reports, some of which you'll see the first of those the Belfast Trust published, and you'll see all of the remainder of the Trust reporting those quality reports in terms of a range of other measures that matter to patients and matter to clinicians. And I think it's about how we respond to that, and I think that's Andrew's point about not letting it get lost in translation. I mean, the response of us all cannot be work harder, work faster, do more of what you're doing. It's back to Fergal's point. If you have process measures, and that's all they are, is process measures. What are the process measures telling us about the system of care, and what are they telling us about how we could provide that care better? Or is there an alternative way whereby we can improve flows, which is back to Gordon's point, or actually are there issues which is telling us around outside of the hospital that we need to address? So it's about how we use those process measures, how we analyse that, and what they tell us about how we should be doing things differently, either inside the hospital or outside of the hospital before people get there, or in terms of actually getting them back into the community.
Any other? Just a wee one, a little one from Roy.
This is the one I indicated at the start. I wanted to speak on earlier on today. The issue of 4 hours target. My perception is that 4 hours after being initially seen, perhaps from a triage nurse, there's a risk if there's a change in someone's condition, and that's why the target's there. That they're then seen by another medical expert inside a 4 hour period. And the 4 hour period is a long time in any accident emergency unit. But when I look at the October to December most recent statistics, I'm very struck by the graph on page 24. It's figure 12, because my perception of that graph is a downward performance in terms of the numbers being seen within 4 hours. And if you actually look at the numbers in terms of the lowest level performance in any year, 2011, it's 73.2% seen in 4 hours in February. The following year, it was down in February to 68.7%. And then the following year, the lowest performance was 66.5%. And these figures are the average amongst every hospital for any month in Northern Ireland. So I'm not zooming in on the worst or the best performance. These are the average figures in terms of the lowest percentage seen. And if you even were to look at the highest percentage of patients who are seen in any month, in April 2011 it was 80.7%. The following year it was down to 79%, and the following year, June 2013, it was down to 77.8%. So again, the biggest percentage of people seen within 4 hours has also declined. Now, if we're going to solve a problem, it's important that we acknowledge that there is a problem. And so when people say we're having better performances, I don't understand how they can say that, because it's not what the statistics say. So, can someone explain what is happening?
Yes, I think that when the Minister committed to a fresh piece of work, this is the initiation of the Improvement Action Group back in the early 2012. The first objective was to work towards reducing the issue of 12-hour breaches, and I think the same stats you have will show a significant improvement on that metric. The intention was to reduce, ideally eliminate 12-hour breaches, and then focus the attention more into the 4-hour issue. They both require intervention across the totality of the system, as just said a moment ago, in terms of prevention, from prevention to discharge. But it is a big challenging issue for the total system, in the context of a lot of other issues to manage, and again to keep the focus on quality. But I think the direct answer to the point you make is that the reference to improvement has been in relation to 12 hours, and we're all very conscious and very concerned with the fact that we're not getting traction on the 4-hour target.
A very valid point. I mean, I think that if we look at the 12 hours, and if we look at the figures that I have, show that if we look at December 2012, we had 579 patients waiting more than 12 hours. Now, that's in the context of the 60, odd thousand odd plus patients. This December it was 168 patients. And
I think if you look at the detailed figures...
I know, you're absolutely right.
If you look at the detailed figures for 4 hours, if you look at the figures for 4 to 6 hours, they have also bulged. So what has happened, you may be dealing with over 12 hours, but it's bulged at an earlier stage in the process.
If you look at the Belfast Trust in relation to the 12 hours, in December of 2012, they had none. And I think that things did, certainly the system, we talked about the pressure in December of 13, they had 79 more than 12 hours. So, and you're right, if you look at the 4 hours over time.
I have heard there's been undue pressure on staff to not record 12-hour waits. And that's why I asked the question that I did.
Okay, I wasn't aware of that. And I mean, if that's the case, then that is reprehensible and should never be the case, Roy. Our views on that.
There's no point whatsoever in either by pressure or by any kind of manipulation. Artificial solutions don't serve anybody.
No.
There has to be an integrity process here, because the real issue is to provide quality of care to patients, and that's just has to be our focus.
The point for raising the figure is that there is still huge stress on the system.
Yes.
And I have acknowledged to the Minister previously, I have seen there has been improvement in Antrim, and it's about the new facility, better flow of patient, it's about additional staff, and it's about the whole hospital starting to work together.
But your point is absolutely valid in relation to the 4 hours, and indeed it hasn't been a dramatic fall, but it is incrementally falling year by year. I think that an element of that has to do with the complexity of the patients that we're receiving. and the complexity continues to grow as people grow older. So, on average, people will develop a chronic illness at the age of 40, and on average, you will develop a further chronic illness every 10 years thereafter. So we're having people presenting, and they may have 3 chronic illnesses, and they may have something else that's wrong with them. And it is very difficult sometimes to actually have those people seen and either admitted or discharged within the 4 hours. And I referred earlier to the issue where the emergency consultant is having discussions with consultants in other parts of the hospital and saying, well, actually, that's not really ours. And those discussions are going on, and that holds things back as well. So I do think that we can do better on it. I honestly think we can do better on it. I think we need to do better on it, and that's, there's no other way around it.
No. Folks, we've just been told that the building's closing at 8, so hopefully that will concentrate people's minds. And it's also quite an unpleasant night. And
Close the meeting now.
no, unfortunately, we've a few more to go, but some folk like Mickey here have got long journeys.
Just in fairness, some of the issues that we want to raise in various different categories have been touched on. It might be worth,
if that has happened,
Chair, if
folks,
that was
just skip
helpful.
over. But we're back now to Roy's substantive questions on resources. Have you anything, Roy?
Particularly on resources, I've noticed in your monitoring bid, we had been told before in December that there was I think it was 43 million of inescapables, and the issues of 30 million was actually handed, but that the issues which, if there are inescapables which would not be covered in your monitoring, would be elective surgery, about TYC, which is about doing things differently to stop people potentially coming to accident and emergency. So it struck me that in terms of in your monitoring, additional pressures perhaps have even emerged, or the pressures at A&E have not been receiving support. And not only that, the trusts were, we were told before Christmas, in deficit, and that to meet the inescapables, my understanding would be savings will have to be made between the original bid and the end of this year. So how on earth is that all going to add up?
Well, it's still very challenging, so I can give you a breakdown of how the money has been allocated. Safety and quality of services 7 million, domiciliary care 5 million, children's services 5 million, unscheduled admissions, winter pressures 7 million, and elective care 6 million. It still leaves pressure on the trusts. I would hope that that gap will be filled as time moves forward. There hopefully will be a bit more money in February as well, given the nature of things that some of the other departments may have some difficulty spending that. And we still have an issue in clinical negligence, and that is something which is genuinely unanticipated, in that the courts have really speeded things up quite significantly. And is the figure this year going to be 58 million? No, in total?
57, yeah.
57 in total. So we had set aside, I think, originally 30 for it, and we're being hit with a bill for 57 million. So that's where we are. And at all times, I've put my accounting officer under immense pressure here about elective surgery, because my view on it is that if we don't do elective surgery, we will build ourselves problems further down the line and further into next year, and actually have more unscheduled admissions to hospital as a consequence. So we have tried to retain the elective surgery, and as far as possible to eat into some of the waiting lists that have been quite historic.
Just as a final comment, I think this past number of weeks has really highlighted the huge pressures that are there, and I don't think it's been fully reflected in the budgets, or sorry, in the in-year monitoring settlement. That's it.
The next section was Mickey's, but we have covered so many issues that we really have.
Sorry, just because I think it was the alternatives, ideas under transforming your care, alternatives to A&E, maybe a co-location in A&E of out of hours, and that I think you did deal with some of that earlier.
Yes, and one of the bids I indicated there was domiciliary care, £5 million. That has always been a big issue. And usually, at this time of the year, whenever people need money, they take money away from domiciliary care. we're actually allocating more money towards it because we think it's very, very important. If we're going to be genuine about transforming our care and genuine about keeping people out of hospitals, that we do invest in domiciliary care.
It's not even taking people out of hospital. I think it's preventing people from going into hospital. Because going into hospital has almost become an alternative. And you know, if that infrastructure isn't there of domiciliary care, then default hospitals. Ian, and you did mention earlier about the number of older people that present at A&E departments, and that is because really there's a whole thing about isolation. There's many reasons, not always necessarily the condition that they have at that particular moment.
My tummy's been rumbling for the last hour, which tells me my body clock's telling me we've gone on far too long. Just 5 minutes to wash up. Just a couple of quick questions emerging from what you've said. How do we compare to the Republic? We've mentioned a lot of the situation with the rest of the UK. How do we compare with our delivery in the Irish Republic, where obviously there'd be similar demographics?
Well, I think I referred to it earlier on the 6 hour. They have a 6 hour wait as opposed to us having a 4 hour wait, and we're delivering 80% within the 4 hours. There, I think there's something like 62 or 3%. Not absolutely precise in that, but on a 6 hour wait.
Yeah, but we can't drill down and find if we're comparing like with like between ourselves and the Republic. There's no way of doing that.
Well, it is like for like.
Well, they have 6 hours, we have 4 hours, so it's a different target.
Yes, but we're actually having 80% of people seen within 6 hours. They are within 4 hours. They're 6 hours. They're not even seeing, I think, 65% at this point. So they are quite badly behind us.
And serious adverse incidents. Is this unique to Northern Ireland, or do other health trusts elsewhere in the UK and Ireland have this?
Over 10,000 reported in England last year.
Similar systems. There are similar systems across other jurisdictions.
I seem to remember when Michael McGimpsey was before us and undertaken that at least a list of them would be given to the Permanent Secretary or the Minister. Would it be helpful to have those arriving on people's desks, given it's 400, just to keep an eye on any trends?
I think we have that role is with the HSEB is to monitor the trends and report and produce learning letters. That's in place. It certainly includes an obligation to alert the department through the early alert system to some particular categories where particular criteria are met. And I would assure you that things haven't changed that much since you did ask me that question some time ago. Chief executives ring me up when they're worried about something. If they're aware of something that is going wrong, then I get a regular flow of phone calls. So there is an information flow that is formal and systematic, that is well structured and well organised, and that's where learning is come out. Because anecdote is dangerous, but where people have a concern, there is good contact, and I'm sure Michael would say similar in terms of
I mean, we do. I mean, just to reiterate that. I mean, and I alluded to this earlier, that as a range of levels, there are learning letters, and I give two examples of SAIs where there was a letter issued following the second and similar circumstances. There is a formal process jointly between the board and the agency where they look at all of the SAIs that have been reported to seek to identify themes, patterns, connections. There's also biannual report where all of those are published. It is a regular theme in terms of engagement with trusts. There will be workshops which will be run. I mean, there are examples, for instance, where a particular issue emerges and there's a particular identified training need or work that was taken forward at a regional level, and the board and the agency will facilitate a workshop with frontline staff in terms of ensuring that improvements are made and learning is disseminated. There's a number of examples that we can provide you with. And also, I think the important thing is that we also, in terms of our accountability arrangements with individual trusts, and also with the board and the agency, we get regular updates in terms of serious adverse incidents or early alerts that have been reported to the department, and actually what actions have been taken by the system.
Glad you mentioned that, Michael, because one thing I've noticed in the last cycle of meetings we've had with the trusts, we have them, as Michael says, twice a year. And I used to worry that the meetings were actually dominated by either finance or the performance metrics. We've actually had a series of meetings where the largest proportion of the time has been in the realm of quality and safety. And that's just an emphasis of where the conversation has been.
We lead off all of the meetings in terms of prevention,
Yep.
disease prevention, the public health agenda with all of our organisations. That presentation and range of issues is there up front, and also, predominantly now the issues are around the quality of care, the experience of care by patients, and how we take forward Quality 2020, our vision for how we improve the quality of health and social care in Northern Ireland. And the real examples and live examples, which I can certainly provide you with, talk to them now or can provide them later if that would be helpful. I'll come back and talk to you about what we're doing under Quality 2020 to improve the quality of our care, not only what we're doing in terms of doing things differently and doing them better, but also how we're getting that information into the public domain to provide the assurance to the public.
Could I thank everyone? I hate to suggest it, but are there any other, we've covered a huge, massive information here today. It's been extremely helpful. Is there any outstanding question that members have that they feel they must ask at this late stage? Surprise, surprise.
I'm at risk of ripping the whole thing up, but not. I am concerned around decision making. I have to be concerned about what the South Eastern Trust did. We have to be concerned about what the Northern Trust did before in terms of residential care. And we have to be concerned that we're only finding out some of this information through the media. And I think that's an important point to make. I don't know if the Minister wants to reflect back on it, but that decisions are made either through pressures elsewhere, but the Minister and the Department and the Board are formed late. Or is it fitting in with some strategic direction and that we're not aware of, and that it kind of serendipitously, in a negative way, falls into a plan? So, in other words, things are happening, and decisions are sometimes made, and we can point to fractures in that decision-making process. And certainly, as the Minister said, strategic and not positive, and I'm sure that's a mild way of describing it.
No, neither strategic nor positive, I suggest. But as it has been established, we have the department, and the department bids for money and then allocates the money, largely through the Health and Social Care Board, but also through the BSO and Public Health Agency, and then that's distributed to the trusts. We have, in terms of the department's role, our role is very clearly to set policy and to ensure that policy is applied, to set the standards and ensure that those are applied, and the CMO has a particular role in that in terms of safety and quality. But in terms of day-to-day operational matters, the trusts have full authority to carry that out, and that is probably right. I think that the best people to actually deliver on operational matters are those who are dealing with it on a daily basis, as opposed to someone from outside of an organisation who thinks that they know better and might know better on occasions, but very often will get it wrong. However, we also have the HSCB in between, and it's our role to commission. Now, that is how it has been established. Were we to take over that role in the department, then we would know a lot more information of what's actually going on in the trusts. But as has been established, the HSCB or the commissioners, in some senses, the department could actually take on that role, but that would be a very big decision for us to take.
It would, but are you hinting at that the process or the decision making or the structure is flawed?
Well, the structures are as they're set up. Are they perfect? No. Are they flawed? They're probably flawed. Are they fundamentally flawed? Probably not. So nothing is perfect in life, and particularly whenever you get to something like health, you really will have problems on occasions that are unanticipated, and you will certainly have issues arising from that.
I just venture a point here that part of the context and approach, as in transforming your care, was to set a clear strategic framework and minimise the risk of non-strategic, non-positive decisions. In other words, to set a broad direction within which everyone knows what they're then seeking to do. So commissioners have a remit to work within the broad approach set out in transforming your care. Trusts are required to continue to work in that direction. That was partly to ensure that where there are future decisions required that might involve, for example, aspects of service reconfiguration, that they're in a strategic context rather than being responses to workforce crisis. We learned the lessons of previous workforce crises, which led to abrupt and unplanned decisions. It's manifestly not perfect yet, but the idea was to set a framework to look at some of the big issues around, such as the approach to the fact that we have a concentration of acute functions in fewer sites and more than diverse functions aligned in the community context. All of those things are set out very clearly in TYC and in the work on the response to it, and that provides a framework. It isn't perfect, but that's the way to do it, and I think that is a fulfilment of a ministerial role, setting direction.
And if the Chair would just grant me one last one, is it time now, given that we're experiencing the pressures, we've seen some of the fragmented decision making, and we've seen some of the flaws and the outputs or negatives that have emerged from that, is it time to rigorously interrogate the strategy with a view to see if it's actually working? Or could it produce further potential pressure? In other words, should we be testing the very decision-making and strategy itself?
You mean the
overall strategy?
The makeup of the
TYC?
Well, I certainly think TYC is a policy which is being implemented. And I think that in terms of the support for that policy, it is almost universal amongst the professionals. That is the right direction. My only issue with it is that we probably aren't going fast enough at it, and I want to see it implemented more quickly. And I find that frustrating that things that I want to see happening, perhaps, there's always problems and issues and so forth. So I will keep chivying at my officials and indeed at the trusts and so forth to ensure that that's the case.
Thank you. I think we'll call it a day. Thank you, Minister. There's a tweet going around. There's only one more job more difficult, and that's the job of David Moyes, the manager of Manchester United.
Success than he has at the minute.
But we do thank you that you've given us 3 hours of your time, which is much appreciated. You've addressed a huge range of issues, and you've brought a strong team with you. We'll need to reflect on all of what's been said. I see you're making the news already. So it's clearly caught the public imagination. And once again, thank you to your team and to the members who stayed behind.
Thanks. Thank you.
All right.
What news is it?